Halo, boleh dengar saya tak?
Dengar.
Dengar ya, okey. Selamat pagi, selamat sejahtera. Ya, sudah pukul 8.10 ya. 8.04, sorry. Jam di meeting ni 8.04. Okey, so kami akan mula sekarang. So, hari ini kita akan ada kursus penjagaan kesihatan primer hepatitis C lah untuk tahun ni. Kami akan bergabung dengan dua PKD lain, PKD Petaling menganjurkan, PKD Kuala Langat dan PKD Gombak ya. Kita bersama-sama menghadiri kursus inilah. So tanpa melengahkan masa, saya menjemput penceramah kita pertama, Dr. Vicky Ayadurit. Dia pakar perubatan keluarga FMS daripada KK Taman Medan ya. Okey. Selamat datang ke kursus. So saya akan mulakan dengan intro kepada program ni. Boleh nampak slides ya? Can everybody see the slides? Can you all see the slides? Can I have response, please? Okay.
Yes.
So today we will talk about hepatitis C training, hepatitis C management in primary care. Okay, so we'll go through certain parts of it. Okay, so we'll be talking about the introduction, what hepatitis C is, the disease, the natural history, also the epidemiology. We're talking about national strategic plan for viral hepatitis and transmission and risk factors. Then there's another module, screening and diagnosis, about screening, diagnosis and assessment. A module on management, counseling, treatment options, and post-treatment follow-up. Prevention, how to reduce harm to the liver to reduce risk of transmission, and patient education. And if we have time, for some FAQ. So, Hep C is a liver disease, as we all know, and it's caused by the hepatitis C virus. It's a very small virus, 55 to 65 nanometer size, and it's an enveloped single-strand RNA virus. So, hepatitis C infection, when you get it, it can cause acute and chronic hepatitis infection, and there's a wide spectrum of severity, from ranging from mild illness which lasts a few weeks to serious lifelong illness. The symptoms of hepatitis C, acute hepatitis C, are very non-specific. They can range from fever, fatigue, jaundice, high-colored stewing, pale stool, or no symptoms at all, which is why people sometimes don't know they have it. The structure of the virus is an enveloped RNA virus of the Flavividae family, and it has 7 genotypes. Okay, this was important earlier because of the different types of treatment needed for different genotypes. So there's 1, 2, 3, 4, 5, 6, and 7. And now we classify into 6 episodes. So one is 1A, 1B, and then 2, 3, 4, 5, 6. So the different genotypes are distributed differently. Some of them, like genotype 1, 2, and 3, are seen globally, while others, like 4, 5, and 6, are endemic in specific regions. So certain people living in certain areas have more propensity to get a certain genotype of the virus. So for Malaysia, our genotype that we see are mostly genotype 1, which is about 30% of our people, and genotype 3, 70%. Okay, the natural history of hepatitis C is this thing. You look at this timeline. When you get the infection, let's say we talk about 100 people getting infected, you all go through acute hepatitis C, some symptomatic, some asymptomatic, some mildly symptomatic. About 15% of them will resolve and clear the virus completely from themselves. So that's about 15 people, and 85 people will go on to become chronic hepatitis C. Of this chronic hepatitis C, 80% will be stable and they don't progress. They just stay as chronic long-term hepatitis C carriers. This is about 60. I'm taking the number of 100 people so you can see the figure of number of people, right? So 68 people of those 100 that initially got Hep C will be stable. 17 proceed to become chronic hepatitis C. Of these 17 people, If you take the initial 100%, 15% will be cirrhotic, will develop cirrhosis, but 75% will be slowly progressive, which means that it's progressing very slowly. They may die of old age before they get any problems with hepatitis. So 4 of these people from the initial 100 will develop cirrhosis, and out of these 4, one will actually go on to develop hepatocellular carcinoma or develop liver failure and die. So it's like a 1 in 10 chance of dying of Hep C if you 1 in 100 chance if you get hepatitis C. Doesn't sound like much, but when you have many infections, there's a lot of people, and there are a lot of people in this category who get cirrhosis and which has a lot of issues on lifestyle as well. So acute hepatitis C, which 15% of people have go into that and come out completely, is clinically mild usually, very often unrecognized and undiagnosed. And if the patient is able to clear the hepatitis C, then they will not have any long-term sequelae. Treatment who are people who are high risk to develop chronic hepatitis, which we will discuss later, these people may need to be started on treatment. But the trouble is, most of the time we don't even know that they have the infection, so it's hard to treat them. Chronic hepatitis C is one of the leading causes of end-stage liver disease and hepatocellular carcinoma and liver-related deaths. So the effect of chronic hepatitis is beyond just the liver-related morbidity, because it has a big impact on the quality of life. If you've seen people with cirrhosis, severe cirrhosis in the wards, you know, they're really emaciated, but they have this abdomen which is so full of ascites. They have this severe pruritus, which is really troublesome to them. It's not a very nice disease to have. Okay, but if you are able to achieve sustained virological response, that means you treat them and they respond well, this is associated with reduction in portal hypertension, hepatic compression, with cancer and liver-related mortality. So treating these people will help them a lot. So for hepatitis C, the natural history, it's usually a chronic, slowly progressive disease, and it's characterized by persistent hepatic inflammation leading to cirrhosis in about 10 to 20% after 20 to 30 years. So this is a long time. It's a slowly progressive disease, which means many patients have it but are walking around relatively well. But once they develop cirrhosis, the annual risk of developing carcinoma is 1 to 5%, and the annual risk of hepatic decompensation is 3 to 6%. And following an episode of decompensation, the risk of death in the following year is 15 to 20%. So once they develop cirrhosis, then things are going to go downhill from there. So we want to prevent them from getting there, which means we have to catch them much earlier in the spectrum. So those people who we expect to have more progression of hepatitis C towards the severe part of the pathway are those who consume a lot of alcohol, more than 30 grams a day in men or 20 grams a day in women. Those who get it at the age more than 40, so apparently if you're older, you get worse prognosis. If you're male, if you have steatosis, if you are immunocompromised, and if you have HIV or Hep B co-infection. So they say at the age of 40 above, your immune response is poorer, so you get less protection. And because estrogen is a protective factor towards liver disease, so male genders do worse. So the epidemiology of Hep C. This is what they call a silent global epidemic of the 21st century. So if you look at Malaysia, we are here. So we are at the 0.8 to 1.3% prevalence rate. We have about worldwide, there are about 70 million people with active or viremic Hep C. So that's a lot of people walking around with hepatitis C. In Malaysia, we have a national strategic plan for viral hepatitis. And this was the plan from 2016 to 2021 with the WHO, whereby 194 member states made a commitment to eliminate viral hepatitis by 2030, which isn't very far away now. It's 9 years, but I think we've been sidetracked a lot for the last 2 years because of COVID. So we're probably back in our plan now. And these ambitious hepatitis elimination targets will require governments to put in place national policies for viral hepatitis. So the plan is for 90% reduction in new cases of chronic hepatitis B and C by 2030, with 65% reduction in deaths due to hepatitis B and C, and 80% of treatment eligible people with chronic Hep B and C having been treated by 2030. So the aim is to find these people and treat them if they are eligible for treatment, so that you can prevent the deaths. So the vision of this strategic plan is that we stop the transmission of viral hepatitis and everyone has access to treatment, prevention, care and treatment for viral hepatitis. And the goal is again to eliminate viral hepatitis as a major health threat by 2030. And the objective is to ensure that 90% of the population living with viral hepatitis are diagnosed. Okay, the problem is many of them don't even know they have it. And then to achieve 90% reduction in new cases of viral hepatitis, and to reduce mortality due to viral hepatitis by 60%, 65% by 2030, and to ensure that 90% of these eligible population for treatment are treated by 2030. So it's like they're trying to do a HIV 90, but they've got a 65 inside there as well. Okay, so basically we want to reduce as many people as we can from getting hepatitis, to get them and diagnose them if they get it, and then to get them onto the treatment cycle. So this is the notification for Hep C. So if you remember, I'm sure in the KKs, most of us tak pernah notify pun hepatitis C case because we never bothered to screen before. It's quite troublesome to screen in KK because you have to ambil darah, then you have to go to hospital, then hospital kata sample tak sampai, and then all this nonsense was happening. So we didn't really diagnose very much until we received the rapid test kits, which really much easier. So from 2010, they said that we also have to notify the chronic cases as well as the acute cases. Initially, I think we only thought we had to notify acute cases. So most of us don't see acute hepatitis C. We may see people coming with liver failure, and then we do the usual screen, look up Hep B, Hep C, and so on. So those cases, I think a lot of us didn't use to notify. But from 2010, they said Hep C or chronic also couldn't notify, so we started notification. And you see the big jump in 2016 onwards. I think that's when the rapid test kits started to come out, and so people were able to screen more and diagnose more. The problem with hepatitis C is that most people are not aware that they are infected. It's like HIV before, and half the population of HIV didn't know they were infected because there was not much screening activities going on. So the same thing with hepatitis C, there was hardly any screening activities before, and that's why there was mostly undiagnosed. And so now we try to increase this 15% who are aware. We can increase the numbers of them. And this is where we in the KK, family medicine specialists and members in the KK, have a big role in screening for hepatitis C. Okay, the routes of transmission for hepatitis C. The problem with hepatitis C diagnosis is the main route is through injecting blood use. And these people are not the people who are going to come to clinic and say, doctor saya nak buat whole body check, doctor saya nak buat saringan. They don't even come to the clinics. So that's the problem with trying to screen the population that's at risk. Okay, 50% get it through sexual transmission, but generally there is some component of connection with the IVDU as well in these cases. Before the screening of our blood products, transfusion contributed to about 10% of hepatitis C transmission, which is now not there. Occupation is only about 4%, and unknown is about 10%. Okay, others is including nosocomial, isogenic, and perinatal. So just like HIV, we can, because we know hepatitis is also partly due to blood exposure. We look at the needle stick injury. We look at the risk of transmission by exposure risk. Okay, so by needle stick injury, either to a healthcare setting, especially in the healthcare setting, if the source patient serology is known, then the risk can be anything between 0 to 10%. And of course, just like HIV, the more volume of blood there is, the longer the injury, the deeper the injury, the higher the risk. And if the patient has got, the source patient has got co-infection with HIV or has a high viral load, then the risk is higher. If you are in a healthcare setting and there's a needle stick injury, but we don't know who the source patient is, or we can't test the source patient, then the risk is usually negligible because the prevalence in the community, like I said, is only about 1%. So the risk is slightly less. In the community setting, we really can't tell. So you're going and doing outreach work somewhere and there's a needle stick injury. It depends on the population that you are in. If you are doing an outreach activity in a drug court, then of course the risk is going to be very high because the prevalence in that group of people is very high. Exposure prone procedure by an infected healthcare worker. If the healthcare worker itself has hepatitis C, the risk is only 0.0 to 3.7%. Certain procedures like open heart surgery and all is higher risk. So similarly, like for HIV, if a healthcare worker has Hep C or HIV, we need to assess the risk of their job scope and whether they can perform that job scope or they have a different job scope. Non-healthcare related occupational sharp injuries is very hard to determine the risk. Again, this depends on the prevalence in that population. Tattoos also risk is not really determined. So we need to assess the risk again individually, and depends on how the tattoo was done, what kind of conditions the tattooing was done. If it's in a proper sterile atmosphere, then there's no risk. Okay, same like HIV, we also have the table shows parts of when blood with hepatitis C is in contact with intact skin, there's no recognized risk. If it's in contact with non-intact skin, then it's very low risk, although there are case reports describing transmission of this. Human bite injuries is very low risk. Heterosexual exposure in general is not a very good way of translating hepatitis C, but it is possible, especially both in stable heterosexual relationships and in those with multiple sexual partners. And it's higher risk if the partner is also co-infected with HIV. And for MSM, this is one of the highest risks, 5 to 8% transmission. So the two highest risks that we see are among our infected drug users and among MSM. So who should be tested for hepatitis C? If you want to keep your resources for the most useful place, then exposed healthcare workers, of course, if there's a liver injury, IV drug users, people with a Hep C infected sexual partner, people with end-stage renal failure undergoing dialysis, because these people are forever in contact with people's blood and blood products, anybody who has received the blood or organ transplantation before 1994 in Malaysia, children of Hep C infected mothers, and people from high-risk prevalence populations, so those living in drug communities and things like that. So these are people you should prioritize for screening if you have low resources for screening. So again, many patients, it's not only Malaysia that a large number of Hep C patients are undiagnosed. Most nations fail to identify patients with Hep C. So if you see in UK, the prevalence of undiagnosed patients is 80%, New Zealand like 70%, US also 70 plus, Germany a bit better, 40%. Yeah. So as few as 15 to 20% of 35 patients of patients are diagnosed overall. And in Asia, I think there's no real studies yet. So that's why we're having this hepatitis C screening program. So they did a survey of primary care physicians, 4,000 primary care physicians, and only there were 1,400 respondents, and only about 50% of them asked patients about Hep C risk factors. So if you think back to your practice, in the last 2 weeks, how many patients did you actually ask about risk of hepatitis C? We're all very good at asking about risk of COVID exposure now, guys, but Hep C, I think, is somewhere in the back of our mind. So if we don't ask about risk factors, we're not going to be able to screen them. Okay, so that's the introduction. I'll go on to my second presentation, which is second slide. Another minute.
Yang ketiganya DA treatment tu, yang lepas doktor tu pindah. Ada lagi lain? Oh. Yang tu.
Okay. Okay, so the next one is about decentralization. Okay, we're trying to bring Hep C treatment to the patient. Okay, before this is quite difficult, so that's why even if you screen patients or test patients, it's very hard for them to get treatment.
Tidak betul share.
Oh.
Bukan share. Share screen. Ini tadi nomor 2. Yang betul tekan balik kan? Oh ya.
Let's see. Sorry, technical as usual. Okay, so decentralization, like I said, is to make it more accessible to the patients. I forgot to mention just now that these slides are credit to Dr. Rosaida from Hospital Ampang at Hospital Serdang. She was the gastro who was really instrumental in pushing us to start treating hepatitis C and KKs through the FIND and the FIND project. Okay. So why do we need to decentralize Hep C? It's because it's a major public health problem. It's a huge burden. And because it's in the community, it's an asymptomatic disease running around in the community, we need to detect it and start treating it. And because it's curable, it's something that we can actually cure, not like HIV where you have to take lifelong treatment. There is treatment and it's readily accessible in KKs now. So globally, WHO estimates there are 58 million people with chronic Hep C infection, and there's about 1.5 million new infections occurring every year. They estimate that in 2019, 290,000 people died from Hep C, and the commonest cause of death was cirrhosis and hepatocellular CA. Antiviral medicines can cure more than 95% of people with Hep C infection, but unfortunately, our access to diagnosis and treatment is low, and there is no vaccine to prevent Hep C, so we need to pick people up when they catch it and treat it. Of course, the best is to prevent, but when you understand that the biggest population who gets Hep C is IVDUs, to talk to them about prevention is rather difficult. So we need to start early.
Kita close dulu, dia tak bergerak.
Tak bergerak.
Sekejap, slide sini tak bergerak. Okay. Kita besarkan lagi.
Yeah.
Ya, tak ada.
Okay. So yeah. So there are some gaps in the HCV hepatitis C care cascade. Okay. So of all people infected, 70% of them are unaware of the infection. So only about 30% are diagnosed. And of these diagnosed, only about 20% actually get enrolled to care. Of these 20%, only 10% actually get treated. And of this, only less than 10% actually go to achieve cure because either they stop treatment halfway or something like that. So from there to there is a big difference. So we're now trying to close these gaps by all the measures that we're trying to do now. So the main thing is to decentralize. Okay, so looking at the sites and the logistic problems or issues related to decentralization. In Malaysia now, 44 hospitals. Sorry. Okay. 44 hospitals and 25 health clinics were enrolled in the FIND study and were able to start treating patients with hepatitis C with a lot of logistic help because of the program that was going on. So there was this national program called FIND where we enroll in this kind of study, where we enroll patients to be screened for hepatitis C among everybody who comes to the KK that we think that has risk factors. And they were given the rapid test kit for screening, which is also a confirmatory test. And any patient who is screened positive with this rapid test, we just had to send them. We were linked to hospitals, okay, easily to hospitals, and the patients could go to the hospitals with appointments made by us. So they just go on the appointment day, and then they get their Hep C viral load tested so that we know whether they're active hepatitis C or they were just old cases. And then from there, they were given treatment and follow up, and everything was done very easily for them. So this was the way we started the FIND study. So now to improve what we need to do to improve access to screening and treatment, the people that are important are the clinicians who treat the hepatitis C, which is now people in KK as well. The allied health professionals, our MAs and staff nurses to help us with the necessary things. Oh, okay. Okay, I think I got one mask and see. Right. Okay, we need also the MLTs to help us with our lab tests, and the pharmacists play a big role with treatment. Okay, so to simplify the care, to streamline it, for diagnosis, we have screening strategies, the main thing being using the rapid test kit at the KKs, and then the access to link them to care. So during the study, it was very easy because we link them straight. We have like personal WhatsApp group with the hospital that looks after our clinic, so it's very easy. Now that the program is over, we again have to find the hospitals that are helping us. And you know, it's very difficult for patients if you ask them, okay, ambil surat ni, pergi hospital, ambil appointment, and then pergi balik masa appointment, especially when your patients are drug addicts. It's very, very hard for them to move around. One, they have no money, they have no transport. Two, every time they keluar daripada daerah, they may get caught by police. So it's very difficult for them. So we have to make it easier for them to access the care. So now we want to access the care in the KK itself. They don't have to go anywhere. They get screened there and they get treated there. And that's why we say no restrictions to therapy, access to therapy. And we expand the treatment capacity by having more drugs available and more amount of drugs. Treatment evaluation, now we don't have to, last time when the earlier management of hepatitis C with the old drugs, you need to know what genotype and which drug can use for which genotype. Now the simple drugs that we have can cover the genotypes that we need to use. If we use simple tools to triage those with and without cirrhosis, we don't have to go and send for scan and stuff. We have tools which will be taught to you later. And treatment is very simple with a daily dose for 8 to 12 weeks. We don't need ribavirin, we don't need worry about so much about drug interactions, and no need for monitoring during treatment. And treatment is much more affordable now. Okay, so we do point of care testing, we confirm the diagnosis, and we do treatment monitoring, all very fast at the KK now. So within the MOH, from the hospital, it has come down to the health clinics, and we also are able to manage people with special conditions like end-stage renal failure and thalassemia, and we also involve civil society and organizations to help us get our patients. We also want to expand beyond the MOH to private hospitals, private clinics, university hospitals, and NGOs to help out. Okay, so testing, screening, and treatment, we want that we hope that testing will be done as a routine procedure during any admission to hospital or any blood taking procedure, and routine checkups, including Hep C, routine checkups for people going for employment or studies and things like that. Also with tagging with other screening like premarital HIV, maybe premarital Hep C as well, antenatal screening as well, and even for Percaso. So these are things that we can try to do. We need to identify the problem with Hep C is many patients are those who come under the poor linkage to care, especially the people living with drugs. Then you have people with limited education, immigrant communities, rural communities, people with language barriers. So they are foreigners, it's going to be very hard for us to communicate with them. Poor social circumstances, people with alcohol addiction, any form of addiction makes it difficult for people to access care. People with mental illness, and in certain countries uninsured patients, and people in prison. So these are all people who actually are infected by hepatitis C, and that's why they find it hard to come forward. Okay, then after logistics, you have to look at the legislation. So Hep C treatment used to be very expensive before, but it costs thousands per patient. But now with strategies like voluntary licensing and compulsory licensing, the drug price has come down tremendously. The one is research and development. So there's research has been done into treatment for special groups, people with infecting drug habits and stage renal failure and hematology. And there's some exploratory research going on for different drugs, newer drugs. Okay, and this will of course include academia and people like FINE, which is a global diagnostics company, DNDi for drugs for neglected diseases like Hep C, NGOs and patient support groups, because MOH alone cannot do this. We use innovation. So for Hep C screening, testing, we can use the gene expert machine rather than having to rely on manual people doing the test. Then we come to leadership and coordination. Of course, you need teamwork to complete this puzzle. You need everybody in the team to help out. They need to be committed. They need to collaborate and persevere. As there must be clarity in the terms of direction and SOP. So this, the vision for Hep C elimination is decentralization on a broader scale, which means more work for us in KK, but which is very satisfying to do because you can actually see the effect. Global vision for the region, comprehensive coverage including all groups and subpopulations, and the time frame is 2019 to 2023, which is already very soon. Okay, and the guiding principles would be that you need to be, the treatment must be accessible, must help to cure, there must be empowerment so that the NGOs can help to bring clients to us and optimize the existing facilities. We cannot say patient can pergi hospital. The patient will not go to hospital, so we have to optimize what we can do at KK. So again, hospital with primary care, with community and civil society need to work together. So WHO's vision to eliminate Hep C by 2030, to have a world where viral hepatitis transmission is halted and everyone living with hepatitis has access to safe, affordable and effective care and treatment. The goal is to eliminate viral hepatitis as a major public health threat by 2030. The 2030 targets are between 6 and 10 million infections reduced to fewer than 1 million by 2030. 1.4 million deaths presently reduced to fewer than 0.5 million. We cannot eliminate deaths because there are a lot of people from the older, before our program started, right? And the framework for action is universal health coverage, continuum of services, and a public health approach. Because this one really, we have to do in primary care because it's very hard for these patients to go to hospital. Yeah, so basically the theme for hepatitis for World Hepatitis Day 2021 is hepatitis can't wait. We need to catch people, diagnose them and treat them fast. Thank you. Thank you, Dr. Vicky. Anybody ada soalan ke apa-apa? Ada soalan boleh type ataupun boleh tanya. Ada ke? Siapa-siapa? Okey ke? Semua boleh dengar? Anybody?
Boleh.
Okay. Our second speaker is Dr. Rupinder Kaur. Dia FMS daripada KK Kelana Jaya. Tapi dia kena pergi tandas sekejap. So, sementara tu ada soalan nak tanya Dr. Vicky, boleh saja tanya. Boleh message ataupun nak tanya pun boleh. Siapa-siapa daripada PKD Kuala Langat, daripada PKD Gombak, ada siapa yang nak tanya? Semua tolong isi kedatangan ya. Tolong isi yang Google Form tu sebab bukan semua yang isi. Berapa ya Sam tak isi?
Baru 32.
Baru 32 orang isi ya. Ada 57 orang sekarang partisipan. Tolong isi borang ya, tolong. Okey, Dr. Rupi telah datang. Okey, sekarang saya berikan mic ni kepada Dr. Rupi lah, Dr. Rupinda daripada KK Kelana Jaya ya.
Kita download.
Ya.
SPT. Okay, close. Atas sekali. Atas sekali. Turun ayat. Close. Lebok di bawah. Okey. Open. Yang folder. Folder bawah tu kuning-kuning. Ayat ni. Pergi yang tadi akhir itu, itu model 2. Itu kan betul punya ni kan. Dan buat macam tadi lah, share screen dulu. Oh, pergi zoom. Tadi, yes. Yang ada muka doktor tu. Yes. Okay. Share screen, model 2 tu. Okay, besar sangat. Kita intro dulu dan kita pergi stop video nanti. Ya, tapi dah tercakap dulu. Kita ada lampu lah, betul. Dulu ada lampu kita tahu.
Boleh dengar kan? Semua boleh dengar?
Boleh.
Okay, thank you. Salam sejahtera and selamat pagi to everyone present today virtually. Thank you for joining our Hepatitis C course. So today I'm going to speak about the screening and diagnosis for hepatitis C in primary care. I think you're sharing. You are screen sharing. Okay, my content for the presentation will be a little bit on introduction, screening and diagnosis, and also assessment. So, as we know, most chronic Hep C infection individuals are asymptomatic and thus they are unaware of their infection. So, a failure to identify them prevents linkage to care and successful control. So, you only will get treatment once you know your diagnosis and you're aware of your diagnosis. So the left side of this cascade is equally more important. And most for Malaysia, the largest gap is not being diagnosed and aware of the infectivity. So what we want to do here is targeted person and populations at risk of screening for people who are at risk of HCV infection. So who do we want to screen? So this is a diagrammatic representation of who should be screened for hepatitis C. So of course, healthcare, emergency medical and public safety workers after needle sticks, sharps or mucosal exposure to hepatitis C infected blood. So the risk of hepatitis C virus infection varies depending upon the frequency of medical procedures, number of injections per person per year, and level of infection control practices. High frequency of injections and low level of infection control can result in high prevalence of Hep C virus in general population. Person on long-term hemodialysis or ever been on hemodialysis means patients with AKIs. Those, like post-COVID, they have AKI, patient on COVID who have AKI, who have ever gone on hemodialysis. So they also have risk of hepatitis C infection among dialysis patient is high in conditions where level of infection control practices is low or ignored. Risk of hepatitis C virus infection also varies depending upon the frequency of medical procedures. number of injections per year. A study reported that 53.9% of patients on dialysis from 1995 and September 1991 were positive for anti-HCV. So it's more than 50%. It's a very high number. People who inject drugs, PWID, people who inject drugs have the highest risk of infection. Globally, the prevalence of hepatitis C virus is 67% among people who inject drugs. In Malaysia, 59% of hepatitis C virus infection acquired through injecting drugs. Recipient of blood and blood products of clotting factor concentrate organ transplant before July 1994. The risk of there is high risk of hep C virus infection via transfusion of unscreened blood and blood products. In 1992, Ministry of Health has outlined that all donated blood and blood products are to be screened for hepatitis C virus. In 1992, they started only in HKL, and in 1994, it was implemented nationwide. Okay. Intranasal illicit drug use. Non-injecting drug use, example through sharing of inhalation equipment of cocaine, is associated with a higher risk of hepatitis C infection. The presence of blood and hepatitis C RNA in the nasal secretions of hepatitis C positive long-term drug sniffers can be transferred onto sniffing implements, example straw, during the simulated intranasal drug use. Person who were ever incarcerated. Person who were incarcerated are at risk for hepatitis C because many people in jails or prison already have hepatitis C. All of them who are in jail definitely have high risk behavior. That's why you are in jail. And God knows whatever other things happen in jail also. So they can transmit each other. All right. Unexplained chronic liver disease and or chronic hepatitis, including elevated ALT levels. So approximately 60 to 70% of chronically hepatitis C virus infected person will eventually develop chronic liver disease. This is your patients who come for your DM follow-up, your hypertension follow-up, and you notice that their ALT is raised. You can actually offer them hepatitis C screening, provided, you rule out other causes. So people with sexual partners who are hepatitis C infected, there is no risk of sexual transmission of hepatitis C among HIV uninfected heterosexual couples and HIV uninfected men who have sex with men, MSM. The risk of sexual transmission is strongly linked to pre-existing HIV infection. Okay, so people with HIV infection are at higher risk of getting hepatitis C. Person with percutaneous or parenteral exposure in an unregulated setting, such as tattoo recipients, they are at higher risk. Person with HIV infection, in particular MSM, are at increased risk of HIV infection through unprotected sex. Persons with HIV infection, so they are at increased risk through unprotected sex. Children who born to HCV infected women. HCV transmission risk is estimated as 4 to 8% among mothers without HIV infection. Transmission risk is estimated as 17 to 25% among mothers with HIV infection. Solid organ donors, either they are deceased or living, there is a risk of HCV infection in an unscreened organ donors. Okay. So I will just recap the natural history of this HCV again, because I think this is a very important point to note. So approximately 55 to 85% of persons infected with HCV will develop chronic infection. Factors associated with spontaneous clearance of hepatitis C virus include younger age, female sex, race other than African American, interleukin 28 BCC genotype, and symptomatic acute infection. The natural history of hepatitis C infection has not been clearly defined because the lack of prospective studies. Our understanding of natural history of hepatitis C is primarily based on retrospective studies. Among those who develop chronic hepatitis C virus infection, an estimated 20 to 30% will develop cirrhosis. It is impossible to predict the rate of fibrosis progression in an individual early on in the infection, but there are some fixed and modifiable factors that have been shown to influence the disease progression. So what are the factors associated with an increased rate of fibrosis progression? Include acquisition of HCV at an older age.
May orang jaga uang saya kemas ya, kita pergi sekali.
Pergi mana?
Ya.
Pergi mana?
Alah lembau ni.
Sorry.
Ya jalan lah.
Increased age independent of duration of infection, male sex, heavy alcohol use, co-infection with HIV or Hep B, hepatic steatosis, and insulin resistance. So individuals who develop hepatitis C related cirrhosis have approximately 1 to 4% risk per year of developing hepatocellular carcinoma, HCC. The natural history of hepatitis C virus can be averted with newly available direct acting antiviral with cure rates exceeding 95% in majority of patients. Okay. Right. So this is a very important graph. So when there is a following infection or inoculation of the hepatitis C virus, so initial phase 1 to 2 weeks, there are no markers of infection may be detected. Okay, there may be no markers detected. The natural cause of the HCV infection is characterized by the appearance of the HCV RNA, then the HCV core P22 antigen in absence of an antibody response further 6 to 10 weeks. So as you can see, the HCV RNA appears first, and then this is for self-resolving HCV infection. And then you see the antigen comes in peaks about 2 weeks only. The RNA comes in first, and then when it goes into seroconversion, the HCV RNA drops, the antigen also drops, and then the anti-HCV comes after the virus clears, and it can be present till decades. So your anti-HCV will be positive lifelong, even though your infection have been resolved. Okay. Now, chronic HCV, if also you notice, the antigen will be present at about 2 weeks, peak, and then it slowly goes off. The HCV RNA will be present throughout the chronic phase, and the anti-HCV will also be present throughout the chronic phase and will be present lifelong. Okay, and if you compare, in self-resolving HCV infection, the anti-HCV actually wanes down. But in the chronic HCV, the anti-HCV doesn't actually wane down. Okay. So now, which serological assay to use? So screening of hepatitis C virus infection should be based on detection of anti-HCV antibodies in serum or plasma by means of immunoassay. Now we have rapid diagnostic tests using serum, plasma, finger stick whole blood, or even saliva as matrices can be used instead of classic enzyme immunoassay. So this is a point of care test which is readily available, okay, at primary care, but not all primary care KK, in some designated primary care KK, and we use anti-HCV antibody screening, and this is thus improves the access of care because it is a point of care testing, right? So currently in Malaysia, we use the RDT-ST BioLine by finger prick or venous whole blood sample. So the screening test, HCV serological markers, you use anti-HCV antibody. So a positive HCV antibody indicates evidence of past or present infection. So when your rapid kit is positive, you still cannot differentiate the patient is having past or present infection. So the antibody-based assays are unable to detect infection soon after acquisition of HCV infection, as antibodies may be detected 2 to 3 months in an individual who have been recently infected. Again, if you go back to the graph earlier I showed, so the antigen peaks at 2 months only. So before that, you may not detect the HCV antigen. So if HCV antibodies are detected the presence of HCV RNA. This is a reflex test. It has to be done. Or alternatively, HCV core antigen, if HCV RNA assays are not available or not affordable, it's very expensive, in serum or plasma should be determined to identify patients with ongoing infection. Okay. So this is some updated WHO guidelines on the HPV and Hep C testing. They say that detection of core HCV antigen where the assays has comparable clinical sensitivity to NAT technologies may be considered as an alternative. Again, directly allowing an reactive HCV antibody serological test results, the use of quantitative or qualitative NAT for detection of HCV RNA is recommended as a preferred strategy to diagnose viremic infection. So testing algorithm, this is a very important chart and a very simple chart. So you conduct anti-HCV antibody testing, you use a rapid diagnostic test or your laboratory-based immunoassay. So your anti-HCV negative, okay, bye-bye. You have not been exposed to HCV. If you're anti-HCV positive, proceed for supplementary testing, use HCV RNA, qualitative or quantitative, or HCV core antigen. So your HCV RNA test positive or your core antigen positive, you have HCV infection. If your HCV RNA test is negative or HCV core antigen is negative, you have no HCV infection. Okay, simple. Again, a recap. Testing for HCV antibody, a positive antibody result indicate that a patient has been infected with hepatitis C at some point. A negative antibody results indicate that the patient has never been infected with hepatitis C. A positive antibody result alone does not distinguish between an active or previous hepatitis C infection. So that's why you have to do this HCV RNA. It is an automatic reflex HCV RNA test for all hepatitis C antibody positive tests. Okay. Can you be reinfected with hepatitis C if you have been cleared with the infection previously? Yes, you may be reinfected if you continue being naughty. You are 20 years old, you got hepatitis C virus, cleared because your immune response is good. But you continue being naughty at 40, your immune response is not as good as when you are 20. You can jolly well get the virus again. And this time you might not spontaneously clear. You might go into cirrhosis and decompensated and then HCC. So it depends. So the the European Association of Study of Liver 2018 recommendations on treatment of hepatitis C virus. So the RNA detection, qualitative and quantitative, should be made by a sensitive assay with a lower limit of detection of less than 15 international units per mil. So less than 15 international units per mil not detected. That means your RNA is negative, but if it's more than that, you have the positive viral load. There is HCV viral load. If HCV RNA testing is not available or not affordable, HCV core antigen detection and quantification by EIA can be used as a surrogate marker for HCV replication. Now, useful to know what HCV confirmation test is available to you. In general, the cost. Now, HCV RNA qualitative tests cost less than quantitative tests, and certain HCV RNA quantitative tests cost similar to qualitative tests, and HCV core antigen tests cost less than HCV RNA. So your rapid test kit is about 30 ringgit to 40 ringgit. Your hepatitis C antigen testing is about, your HCV antibody testing is about 70 ringgit. Now your HCV RNA is about 600 to 700 ringgit per test. Okay. I couldn't get how much the government rate is because when I called up the lab di Sungai Buloh, they said kita tak tanya harga doktor, semua free saja, kita buat saja. Tetapi I called up a few private labs, some quoted 800, 715, 600. Okay. So the guidelines of recommendation, the first one is the WHO. Everybody must know this logo, the WHO logo. An assay to detect, I mean, not must know lah, good to know lah. Okay, an assay to detect HCV core P22 antigen, which has comparable clinical sensitivity to NAT, is an alternative to NAT to diagnose viremic infection. And then the European Association said that the HCV core antigen is a surrogate marker of HCV replication. Core antigen detection can be used instead of HCV RNA detection to diagnose acute or chronic infection. And then the Asian Pacific Association said HCV antigen assays, another method of detection of anti-HCV infection, have been commercially available for a couple of years, and they can detect both free antigen and antibody combined antigen. So again, reflex testing, your antibody positive, please go on and test for your HCV RNA. Okay, it will increase the linkage of care, thus diagnosis and treatment. Okay, another chart, which is also very good and important. So this is a simplified way to know which stage of the disease your patient is. So in early stage, the ALT, your alanine transferase, will be negative. Your anti-HCV will be negative. Your RNA will be positive. You may not have symptoms and you will be contagious. In early acute, ALT positive, anti-HCV will be negative. HCV RNA will be positive. You may not or may have symptoms. You will be contagious. In acute phase, everything will be positive, okay? Because you have everything is there. And in resolve phase, only the anti-HCV will be present. In chronic phase, your ALT will be raised, your anti-HCV will be raised, will be present, your HCV RNA will be present. You will not have symptoms. You will be contagious. And in occult infection, that means if there is presence of HCV RNA in the liver and in the peripheral blood mononuclear cells in the absence of detectable viral RNA in your serum. So your RNA will be negative, but your ALT will be raised, your anti-HCV will be positive, and you will be contagious. Right, so interpretation of results and further action. So if your anti-HCV is positive and your HCV RNA is positive, active infection, okay? So you have to do counseling on do's and don'ts, health promotion of modifiable factors, your ethanol consumption, your obesity, patient should reduce weight, diabetes control, vaccinations, your influenza, pneumococcal, whatever. OST is not original soundtrack, but opioid substitution therapy and harm reduction. And you need to assess fibrosis. They have invasive and non-invasive ways. So I will touch about it next slide. And enrollment to care and treatment. So if your anti-HCV is positive and your NAT is negative, it's a false positive anti-HCV or previous HCV infection with spontaneous clearance. So you repeat the HCV RNA in 3 months. If HCV RNA is negative, no infective education, health education for high-risk behavior, and bye-bye. Anti-HCV positive, HCV core antigen negative. False, it could be false positive anti-HCV or previous HCV infection with previous spontaneous clearance. Okay. So in conclusion, a combined pattern of HCV antibody screening followed by sequential confirmation with antigen and RNA on antigen negative will provide equal or better diagnostic performance at lower cost over a broad range of scenarios. So all anti-HCV antibody positive must be notified. Okay, anybody in your rapid test kit positive, regardless your HCV RNA might not be positive, but he's got, because once your HCV antibody is positive, you have spontaneously cleared the infection or you are having the infection, so you must notify. Okay. Now, the contribution of comorbidities to the progression of liver disease must be evaluated and appropriate corrective measures must be implemented. Liver disease severity must be assessed prior to therapy. Patients with cirrhosis must be identified as their treatment regimen must be adjusted, and post-treatment surveillance for HCC is mandatory. Now, if patient has cirrhosis, we do not treat them in primary care. We refer them off. Okay. Now, staging, the gold standard is liver biopsy, but there are a lot of pros and cons with the liver biopsy. There's also transient elastography or fibroscan. So if the fibroscan says more than 12.5% kilopascal, it goes to cirrhosis. But what we can use in our settings is we have very good negative predictive value for APRI and FIB-4 scoring. Okay, no need to memorize. Everything now is on got app. Everything is available. Google saja will come out. So you can do the APRI scoring and FIB-4 scoring. So less than 0.5, no cirrhosis. Less than 1.45 for FIB-4 scoring rules out cirrhosis. Okay. So again, the cutoff for FIB-4 less than 1.05 and high cutoff is 1.5. Okay, and for that's for FIB-4 and APRI both. So in summary, promotion and training is very important. Screening for high index of suspicion, strategize. Example, 100% among MMT clients, RVD, healthcare staff, and SCI, OPD or MCH with high risk with IVDU patients, blood donors prior to 1994, needle stick injuries, tattoos, body piercing, and people who are interested to screen, right? So the testing is definitely your rapid diagnostic test kits in your KK or immunoassay with reflex testing, and assessment with serum biomarkers and notification. Okay, that's all from my side. Thank you very much. Any questions to Dr. Rupi? Okay, terima kasih saya ucapkan kepada Dr. Rupinder, pakar perubatan keluarga daripada KK Kelanjaya. Okay, seterusnya saya menjemput Puan C. Kahmi, pegawai farmasi daripada Klinik Kesihatan Seri Kembangan, untuk menyampaikan topik berkenaan strategi saringan rawatan susulan dan interaksi ubat rawatan. Silakan.
Hello, good morning. Can you all hear me? Oh, okay. Hello, good morning. Can you hear me? Okay. So I'm Mrs. from Klinik Penjagaan. My name is Amy Sikame. I'm here to talk about it.
Close dulu, foto. Mana? Itu ya.
Okay. Kakak ada email to this account. Oh, I put. Email, I just email. Hello, good morning. My name is Sikame from Clinic Kepada. I'm a pharmacist that's taking care of the Hep C treatments for penyakit. So my topic today will be about screening strategies, follow-up treatments, and drug interactions. But because just now Dr. Vinda has talked mainly about screening, so I'll do a very, very brief touch and go, mainly from a pharmacist perspective. So brief introduction also done by Dr. Vicky, but I'll just do a very quick summary of it. So generally, this all has been spoken about earlier. So actually, oh, 30. Yeah. Ada. Jadi, so sekarang dah boleh. Okay. So yang ni, I think it's lagging a bit lah. So generally, right, it's a liver disease caused by hepatitis C virus. So it spreads via infected blood and causes liver inflammation. So all this can, if left untreated, it will proceed to liver failure and even cancer lah, ACC. So this is the same diagram that we have seen under Dr. Vicky's slides. Yes.
Your voice is very soft.
Oh, okay.
Cuba buat slideshow.
Kalau buat usaha
Cuba
ni,
enable editing lepas tu. Right.
ni,
Okay lah.
enable editing mana?
Tak perlu.
Dekat
Okay
ni.
lah.
Dekat.
Next slide. Sekarang dekat brief introduction. FC.
Yes. So okay, this one we already talked about in Dr. Vicky's slide lah. So I'll just do a brief summary about it. So liver disease is caused by hepatitis C virus and it spreads via infected blood and causes liver inflammation. If left untreated, it progresses into scarring of liver tissue, which is cirrhosis, liver failure, and also HCC. Okay, this is also the same slide, the natural progression of the Hep C virus infection. So statistically, there is an estimated of 71 million who have chronic hepatitis C infection, and approximately 399,000 people die every year from it. And generally, those who are who has chronic ACV infection, the risk of cirrhosis of liver is between 15 to 30 within 20 years. So Generally, the WHO estimates an approximate 3% of the world's population to be infected with Hep C, and it's one of the most prevalent blood-borne diseases in the world. And in Malaysia, estimated of 453,000 were infected who are positive in 2019. And according to, I'll just skip mainly a lot of things because a lot of this has been spoken about previously. So according to 2017 analysis, incidence rate is about 9.54 per 100,000, and mortality rate is about 0.3 per 100,000. Okay. So most common genotype is 3 and 1. And generally, this is just a small graph about how the projection of hepatitis C infections are and its complications. Usually the graph is just going up because more and more people are getting notified with more and more people are diagnosed with hepatitis C. So this is the same also, National Strategic Plan. Also, it's really talked about by Dr. Vicky. So we'll move on to screening strategies. So this is again the repeat of statistics only. So same thing. A total of 25,000 people have been notified in between 2003 and 2018. And as you can see, there is also an increasing trend of awareness in both healthcare workers and also the public, particularly among high-risk population about this condition. And generally, it's done in hospitals and at the central and regional laboratories. But nowadays, we are getting, they have been rapid diagnostic tests that has been done in the clinics. So screening of these patients have become decentralized. And this is just a small diagram on how they do it. And just now, Dr. Rupinder already went into great detail about this matter as well. So same thing, high-risk population, blood donors, organ donors, healthcare workers, those who are working in high-risk populations, people who inject drugs, so those who are using the drug users, and then foreign workers, children of infected mothers, and also those people going under dialysis. And this is just a process that is an example of a process that's done in KTM. Because my clinic at the time, they didn't really do much of this. They just do the screening and send girls to hospitals. So for here in KTM, the blood is taken to check for antigen, Hep C antigen, and later it will be sent to hospital Chalam. They will review back the patients in 3 weeks or in a month. And if let's say it's reactive, the blood is taken for AST to check for liver status. And depending on the result, patient is either referred to hospital if let's say patient is cirrhotic, or treated in KK itself if they are non-cirrhotic. And so for a pharmacist, in terms of screening, we don't really have so much hands-on in the screening, but we can assist in helping to see whether the patient is at risk or not. We can also talk to them and try to assess the patient to see whether they might potentially be hepatitis C infected. And generally, those who are infected should be counseled about the importance of adherence to get SPR. And generally, we also have to do a pre-treatment assessment to get the patient's understanding of the treatment goals, and to provide education about their treatment and make sure that they come back for follow-ups. Because usually those patients that are going to be on the treatment will be those who use drugs before this, who are on methadone also. So it might be a bit difficult to try to get through to them, but you need to talk to them properly and try to communicate with these people to try to encourage them to come and come back for follow-ups, make sure that they understand what's their treatment goals, why they are taking these medicines, and so on. So again, we're not really direct for pharmacists. We are not really directly involved in screening, but generally we are assisting to identify potential patients, like especially because pharmacists are involved in methadone replacement therapy. So we will be encountering a lot of these patients who use drugs previously. So we can potentially help to just see and ask a lot of questions about their risk. Like I have encountered patients who are infected, but they didn't bring in their spouse to check. So what I did was I just asked them to try one day, arrange with my KK to try to bring their spouse over, so at least we check whether they have Hep C or not. So for pre-treatment checks, so before we start the treatment, there'll be physical examination, screenings, confirmation tests, and other baseline tests. This is just the basics. Then for a pharmacist role in pre-treatment assessment, you first have to get a complete medication history. So all prescribed medications that patient have, maybe they have diabetes medicine, maybe they have hypertension medicines. So we try to get the full list from them. Over-the-counter medicine, if let's say, for example, they have migraines, they're taking extra Panadol or other medications. Supplements, if let's say patient is taking either multivitamins or any other vitamins, and herbal or traditional medicine. And this includes like herbal drinks, herbal soups that that patient might have, and it might have a potential interaction with our medicines next time. So we have to get the whole list from them. Okay. So also, yeah, same thing. We have to check for potential drug-drug interaction, or perhaps if they have any supplements or any herbal medication, they might interact with our Hep C medications. We still have to get and check everything before we start the treatment. For follow-up, this one more like what is the treatment? So last time, what they used to have would be the interferon and ribavirin combination. So it's an injection, and it used to last for about 48 weeks. And this is rather suboptimal because only half of the patients get cured on this treatment. So the side effects were quite severe because of the ribavirin, and most of them cannot tolerate it because of either the side effects just so bad, or if there's a contraindication for them to use it. And it was also quite expensive at the time. And currently what we have would be the DAAs, so the oral direct acting antivirals. And what we are using is sulfosylate, and they combine it with other DAAs. And it's instead of injection, it's non-invasive oral, and it's only for 12 weeks, depending on whether they have cirrhosis or not. And cure rates are over 90%. That's side effect as well. Okay. And that's the original price. Right now, because we have the compulsory licensing, the price is reduced now because we're getting the generics instead of the originals. Okay, so this is just what they have. This is just the compulsory licensing for sulfosylate that we just got recently. So the price last time was about $11,000 before the compulsory licensing. Now it's about estimated of $99 for the whole treatment. So it's much cheaper compared to last time. So current price would be about 1,200 ringgit for the entire treatment per patient, compared to 150,000 before this. Okay, so this one is just a small diagram just to show you the process of what they will do for this kind of patients. So from patients with confirmed viremia, and then the age, depending, we only treat for those older than 12, but we don't really, in Malaysia, we don't really treat younger than 18. We treat older than 18 only. Okay. and as you can see there is a non-cirrhotic and there's a cirrhotic patient treatment. There's a difference for it. So the non-cirrhotic will be about 12 weeks, cirrhotic will be about 24 weeks, depending on which one they take. What we have in Malaysia that in KK mainly, we do not have Riverine. This is actually just the hospitals because they use it for treatment of cirrhotic type of hepatitis C infection. But what we do have in KK will be sulfosylphosphate and diclofenac. So generally, this the dose of sulfos will be 400 mg per tablet, and it's in the pack of 28. And for diclofenac, there is two strengths of tablet, which is 60 mg and 30 mg. So for this kind of situation, also just to mention that these tablets cannot be cut lah. So if let's say your patient require the 30 mg, please do not cut the 60 mg. You need to order the 30 mg. Okay. So for first visit for pharmacists, what we have to do is we have to issue them a drug diary. So we need to explain what is it for and teach them how to fill it accordingly. So every time they eat the, later I'll show you the example, every time they eat the tablets, they need to mark it per day. Okay. And then what we have to do is we have to provide adequate counseling to ensure that patient has understanding of their medication and also to encourage them to have proper adherence to the treatment. And what you have to do is you have to build rapport and make sure that the patient has a means to contact the pharmacist or contact the hospital or contact the clinic or contact the doctor in case they have any inquiry. So generally, if let's say for certain, I actually separate my patients into methadone patients and non-methadone so that it's easy for me to track. So if those who are in methadone, they usually take it daily, they come for dots, so they can come and see me whenever. Whereas those who are non-methadone, usually I'll just provide them with the pharmacist phone number, pharmacy phone number, or the KK phone number, just so that they can easily call up in case they have anything. So this is the patient drug diary. So as you can see, there'll be patient name and everything. We just have to write down everything. Just make sure that everything's filled up. The genotyping, I don't know about other KK, but last time we used to do genotyping. Now they don't really do genotyping anymore because sulfosylphosphate and also diclofenac can be used for both genotype 1 and 3. So nowadays our doctors don't really do the genotyping. So for this particular case, as you can see in the second page, what we do is when initiation, the day itself, right, I will tell patients straight away to take one tablet in front of me and then ask them to write down how, like you see that there, day number 1, and then write today's date, and then ask them to take what medicine they take. So I'll make sure that they do it in front of me so that they will get used to it and they will know how to do it when they go back home next time. So for counseling sheet, this is what I did. So what I did was I summarized all the basic points and I give them as an additional aid for patients every time when they come and see me. So on the first visit, I'll provide them this sheet. And if let's say I explain anything, I'll explain everything in the sheet itself. But if let's say they forget or perhaps they are not sure, they can also refer back to here, this sheet. Or if let's say I ask them, if let's say they are falling sick or they have to go to another GP to see for their other conditions, they can perhaps bring this sheet and just show to the GP or show to the hospital that they have this condition, and they can also refer to this additional counseling sheet. So I just summarized the basic stuff there. And during follow-up visits, what we have to do is we have to check whether patient has allergies or perhaps they have an ADR from the medication. So generally speaking, if let's say we usually do collab with treating physicians, if let's say there is an intolerable side effect or there is allergic. So I had patients who had skin rash, quite a bad skin rash after they took this medicine. I saw them again in 1 month's time. And what I did was I consulted my MO. And in the end, we decided it's probably like a small symptomatic thing, and we just give cream. Patient keep taking for the total of 3 months, and he was fine after that, after just using the steroid cream. So that's just an example. This one is actually workflow for pharmacists. If anyone wants, you have to just you can check the protocol for hepatitis medication adherence therapy adherence clinic, the hepatitis and that. So it's all there. If any pharmacists want to refer, it's quite long, so I don't talk about it too much. So we can move on to drug interactions. So this is your main thing that you will see as a pharmacist in terms of treatment for these hepatitis C patients. So the common side effect for our in KK setting for DACLA and so forth will be headache and fatigue, and usually it will be in the first week first week or second week. Then after that it will be gone already by the time. So if your patient is a bit afraid to try or afraid to, maybe they're just scared that if they take this medicine there will be more side effect, just let them know it's about 1 to 2 weeks and then it will be gone already. Most of the time it won't last longer than that, and it's only a chance of 10% probability. Okay. So what we use, it would be the Liverpool hepatitis interaction. This one there is available in the website, so the website is there, or perhaps you can get the smartphone application as well, and it's quite simple. What they do is they just have to select the hepatitis C drugs, so you'll be DACLA and so forth. There's actually a really long list, but the ones that are in Malaysia is only these two. And then you click on whatever medication that they have. Let's say, for example, I pick the amiodarone, and you can see that on the smaller window there, there's a do not co-administer, means that there is a contraindication. So we cannot give these medicines together, and they even provide a summary on why it shouldn't be given. Okay, so this is actually really useful if, let's say, your patients have a lot of comorbids and a lot of other medications. And this one, they'll update it all the time in the app also. So just keep your app updated and it'll be fine. So for special populations, so in pregnancy, we do not encourage patient to start on treatment if, let's say, patient is pregnant, or if, let's say, they are women who are at productive age. We try to discourage them from getting pregnant if they want to start this medication. So for sulfonylurea, there is for now no known embryo toxicity, but we still differ because there is a potential for it for DACLA. Okay. But as you can see that since this is a new medication, there is still no adequate evidence for all DAAs. But if, let's say, they go to hospitals and they have to take urine and intron and all that, that one is contraindicated. But for, I mean, generally, if they want to start, just try to defer them if, let's say, they are pregnant. For major contraindications, DACLA, generally, if there is any drug that affects the liver enzyme CYP3A, we need to be a bit more careful. We need to check it's not an absolute contraindication, it's more like a warning for DACLA. Whereas the absolute contraindication would be sulfonylurea. You cannot administer amiodarone together with sulfonylurea. And there is a caution for beta blocker use, but it depends. And for renal failure, those who have EGFR of less than 30, we do not start that. That one's also an absolute contraindication. And some of the common drug interactions that I will talk about would be that's especially for Hep C co-infected would be DACLA and ephedrine. So generally, co-administration of these medications will decrease the DACLA, AUC, Cmax, and Cmin. So it will reduce the effectiveness of the Hep C medications. Generally, the counter for this would be to add an additional DACLA of 30 mg. So your patients who are having Hep C, who have ephedrine, usually will have 90 mg of DACLA instead of the normal 60 mg. Okay. Then for this is the common ones that I've encountered in my KK. So for amlodipine, there is a bit of a effect on the CYP3A4. So usually I will try to switch it out instead of using amlodipine. I will switch it out to something else. So, but it's again a risk versus benefit thing. And because the treatment is only for 3 months, I'll just say it's only temporary. Then later on, they can just change back to the original blood pressure medicine. For simvastatin, there is a potential for it, but it hasn't been studied that well. Generally, it's this medication will increase the simvastatin concentration, and because of that, the patient might experience more side effects from simvastatin. So there'll be more muscle pain and everything. So what we do is perhaps we can suggest the doctor to reduce the dose of Simbas, or we closely monitor their adverse effect, such as myopathy. So because the drugs and drug usually is quite new, there is not much data about drug and food interaction or drug and complementary medication. So what I would suggest to patient is for the 3 months, for KKs, I think it will be 3 months. 3 months of treatment, try not to take any other supplement, no herbal soups, no ginseng whatsoever, no janu, anything. So everything just stop, especially the non-important stuff like vitamin C, all the supplements, right, that are not crucial for their condition. Then I'll just tell them just stop for the 3 months. Later on, just continue after that, after they are finished with the DAA treatment. Okay, and that's generally it lah. Okay. Thank you so much for your time. Any questions?
Puan boleh buka cek.
Cek.
Cek atas.
Any judge?
Atas. Atas. Hai. Pola yang share. Dengan soalan tu Puan.
Mana?
Having different
Can you
genotypes.
show the slides of regime having different genotypes?
Dua soalan.
Take twice.
Recording in progress.
Okay, this one is it?
Ada present, right? Present.
So, there's actually just use precaution, to be honest. So, oh, okay. This yang tu je. Okay, the thing is, right, for beta blocker and sulfosylvir, it's just a caution, it's not really a contraindication. Even because this is just a recommendation only. And when I checked in, I actually have been checking the Liverpool Hepatitis C interaction checker. That there is not really no real interaction between sulfos and beta blocker. It's just a caution thing. Even like for those patients with amlodipine, I will actually advise patients to change to bisoprolol for the 3 months, because when I checked it, right, there is no interaction with it. It's just a caution thing. This one I actually took it from under EASL recommendation, but I don't know why that it's written caution for beta blocker, but when I check it under Liverpool, there is no proper interaction. What I advise, right, will be individually, you need to check under the interaction checker, will be safer.
Suppose a lot of patients taking traditional. How do you check interactions for traditional treatment? Okay. How for patients who take traditional medication?
Traditional medicine.
Yeah, how do you use interactive? Because they use all kinds of weird things, right?
Oh, okay. So for traditional medicine, for traditional medicine, I will advise them to stop for the 3 months. So because what I will do is I'll try to emphasize to all my patients, if let's say you do not take this medicine properly, or perhaps if they mix it together, there might be a chance of reduction of effectiveness in terms of the Hep C medicine. And because traditional medicines are not really a pure medication, not a pure thing, there's a lot of components, a lot of chemicals that's mixed inside the traditional medicine. We do not really know what's the effect of this traditional medicine on the medication. We are afraid that if let's say the traditional medicine will reduce the effect of the Hep C medication, then your virus is not going to be able to get the full effect of the medication, and there might be a treatment failure later, and the worst case scenario will be the virus gets resistance instead. And for the time being, Malaysia we only have two medications that we can use in terms of the case setting, and that's the only DA we have right now for the time being. So I will really emphasize the patient just stop for the 3 months if it's not necessary . Any other questions? Just now you want to see the genotype, right? Is there any other questions before we proceed to the next topic?
Yang belakang tu pun dah jawab tadi kan?
Yang mana? Yang interaction tu dah. Because yang ni actually I just checked in the recommendation only the caution punya. Because this is what they mentioned in recommendation, that there is a caution for beta blocker, but the most updated will be this one lah. So this one, when I check bisoprolol, ethanol, actually there is no real interaction. So even certain medications, I will actually change it to biso, like especially for amlodipine. That one I'll actually mention to the doctor, if possible, to change it to bisoprolol for 3 months. Then later we change it back. If there's no question, I pass to the next speaker.
Terima kasih diucapkan. kepada terima kasih diucapkan kepada Puan C kami. Di atas penerangan yang sangat menarik. Okay, seterusnya saya jemput Dr. Vicky Vigneswari Ayadurai, pakar perubatan kesihatan keluarga, Jusasi daripada Klinik Kesihatan Taman Medan, untuk topik seterusnya rawatan hepatitis C dan DAA. Persilakan.
Okay, thank you. Since we are going for time, okay, kena buka mask again. How about everybody buka your screen? Can we see everyone? Because it's really strange presenting macam ni, macam cakap seorang diri je. I feel like really weird. Just everybody say hello first, then we sambung.
Tak tahu lah, kena panggil orang.
Hello.
Hello Dr. Vicky.
Kita nak pakai sini ke sana?
Hello Dr. Vicky.
Tapi saya tak hantar lagi.
Hello Doktor. Hello. Hello.
Ini nampak ramai. Boleh lambai-lambai. Doktor tu ada dekat sini dah? Belum?
Tak.
Ada. So, kita nak pakai
Saya akan present dari sini lah.
Sini. So, nanti doktor just share.
Ada orang hidup. It's good to see faces. It's like really talking to a wall. Smile lah Khairi. Kata Khairi smile. Okay. Hi everyone. Everybody's awake, I guess. Alright, so I will start now. Okay, I'm going to try to do it from my PC laptop because I forgot to email the slides. Mana share slide ni? Kena minta tolong. Warna hijau. I tak ada warna hijau dekat IP nya. That's it here. Mana pergi? Mana aku punya benda hilang? Where's my Zoom?
Tekan.
Dia tak ada.
Bagi besar dulu. Share screen. Mana segmennya? Kita tengok first slide dia.
Oh, so nak pakai sana. Saya ada email dah.
Ada email?
Yeah. Sorry, some technical glitch. I need to transfer again.
Okay. Kata stop ni. Bukan ni kan? Slide tu.
Bukan.
Boleh, tapi dia akan ni lah. Apa? Dia lagging. Sekejap untuk sini.
This to give you all time to drink your coffee ke, run around ke, whatever, toilet break.
Sama juga. Macam biasalah doktor. Just share screen. Ni attachment module. Dah pun dah berubah. Doktor boleh letak situ dan boleh nampak ni doktor ni pandangan mata. Okey, dah start.
Okay. Sorry.
Tekan ni. That should be.
All right. So we go to the next one, which is about treatment. Right. So we'll be talking about goals of treatment, who we want to treat, what's the pre-treatment counseling that we need to do, and assessment, what are the options that we have, which is very simple, post-treatment follow-up, and how to treat co-infection. Okay, so the goals of treatment is to cure people, right? So the primary goal is to eradicate Hep C infection and achieve biological cure. This is what we call SVR, or sustained virological what's the R? Response. Yes. Sorry. Okay, and secondary goal is to slow disease progression, to improve the histology of the liver, to reduce the risk of hepatocellular carcinoma, and to improve health-related quality of life. And all of this basically hopefully to prevent complications from Hep C infection. Okay, and of course we want to reduce all-cause mortality and liver-related death, to health adverse consequences of the disease, including end-stage liver disease and carcinoma. Okay, so this is our grand aim of treatment. And the solution is the antiviral therapy that we have, because it can achieve permanent eradication of the virus, which is basically cure. So sustained virological response in 12 weeks is where we have undetectable Hep C virus levels 3 months after we complete the treatment. And this is considered cure, as the virus will remain undetectable in 99% of the cases. So if you look at different categories of patients, all patients who are mono-infected but who have abnormal LFT, who have combo therapy, normal LFT, those with HIV co-infection, different groups of people, all of them actually achieve a durable viral response. So if they're treated, it's really a very happy kind of treatment, because you know our diabetic patients, you cakap berbulan-bulan, bertahun-tahun pun sama juga HbA1c tak turun-turun. You talk to your HIV patients, yes, they do well, viral load memang suppressed, tapi they have to be on treatment forever and ever and ever. Whereas Hep C, you see them, you treat them, and 6 months later, habis treatment, bye-bye, you don't have to come back. So it's like something really, you can put an end to something, which is quite satisfying. Okay, so who do we treat at primary care? We recommend that we treat all patients who have hepatitis C, okay, except for those who have very short life expectancy, which is not going to be changed the prognosis by treating the hepatitis C. Okay. So basically almost everyone we see, because if they come to KK, generally they're not like going to die tomorrow. Okay, so we should be able to treat most of them. Echo. How come we got no echo? Kita tak ada echo pula. Are we still hearing an echo? Now echo? Still. Everything off already, right? This bit off. Was it now? Testing this now. Is it still an echo?
No more echo. Thank you.
It sounds so clear here. Better. Shock sendiri. Better. Clear. Okay, right. So so those whose life expectancy is short because of liver disease, they can be treated, but this one you need to send off to the hepatologist. No need for primary care to sibuk-sibuk. Okay, so we treat basically like a pharmacist said just now, some countries I think they treat from 12 onwards, but in Malaysia we treat adults 18 and above. Those in primary care, we treat those who are non-cirrhotic and who have never had treatment before, treatment naive. And also we can treat them if they have HIV co-infection. So it's quite a wide range. And in fact, in some KKs, especially in Kedah, because the head gastro person, Dr. Razi, is in Kedah, and he has trained the clinics in Kedah, the FMS in Kedah, so they even treat cirrhotic patients in Kedah. Okay, but in Selangor, let's just stick to the non-cirrhotics because we've got enough of those as well. So the factors that we need to consider when we want to prioritize treatment is, number one, the patient's willingness to start and adhere to treatment and follow up. So again, I remind that most of the time the patients that we have for hepatitis C are drug addicts. And these are not the most easy people to keep to regime, to keep to follow up, to come, even though it's only 3 months. Okay. So when we did the FIND study in Taman Medan, our clients were mostly methadone patients. And you know, we know them well, we dah cakap banyak-banyak dengan them, we already explained to them that this is just for 3 months. Unfortunately, during the study, they have to go to hospital campak. We can start everything, we can treat, we can screen, we can confirm, and then we can get the appointment, but they still had to go to hospital for treatment. And it was very, very difficult for so many of them. Some of them went for one visit and then they didn't go for the second visit. So sampai my pharmacist, she got the Google map, she got the which train line takes them to go to Ampang, where to get down, how to go, still boleh sesat. And then we get one guy to say, okay, tak apa doktor, saya akan bawa kawan saya. So he comes to the clinic, the kawan tak datang. The next day the kawan datang, he doesn't come. So the appointment we keep, and luckily because it was a study, we have contact directly with the people in Ampang Hospital, so we can call them and say, okay, sorry, staff patient tak datang hari ni, can you give me a new appointment? Can you give me a new appointment? So it's like going on and on. And then ada yang on the way pergi kena tangkap. So after that, biar kawan-kawan tak nak pergi. So even though it was a quite interactive appointment system, they still had difficulty going for it. So now that we do it in the KK, it's so much easier, especially for maternal. Memang they come into the clinic regularly, and even the non-maternal find it much easier just to come to the KK, because initially itself they came to the KK because we're very close to them, right? So, but again, have to stress to them, just 3 months, you have to be adherent for 3 months for this. Even after 3 months, sometimes they don't come back for the follow-up, they don't come back for the screening. Tak apa, at least we treated them, and we hope and pray that they responded well and that they are negative lah, cleared already, right? And patients who are at risk of accelerated fibrosis, that means people with like other co-infections like hepatitis B or HIV, these people we should start them treatment quickly, okay? Because before they get into fibrosis and then cannot be treated. Those that we need to refer to secondary or tertiary centers, those with increased risk of death, like those with severe fibrosis or cirrhosis, those with post liver or other organ transplantation, we don't want to mess around with them in KK, so these will be refer. Patients with Hep B infection, we can refer. Treatment naive and treatment experienced patients with compensated or decompensated liver disease. So if they have liver disease which is quite advanced, we don't want to treat them at KK. And those with extrahepatic manifestations and evidence of end organ damage, like debilitating fatigue, vasculitis, lymphopolysaccharidosis disorders, these guys we don't want to handle at KK. So the pre-treatment screening and counseling that we do, this is very important. First, how we set the patient up for treatment is important. If we don't give them the proper intro into the system, then they might end up like not following up later. So that's where it's going to get difficult for us. So we need to document and get the proper history from them to know how they got the Hep C. It's important to know how, because then we need to know how to advise them to prevent further infections. Like we said, after they clear and get treated and cured, if they get exposed to the same risk factors, the chances of getting Hep C again is there. So we might as well start counseling them from now. Whether they have other medical comorbidities like diabetes or non-alcoholic fatty liver disease. We need to review what medications they're taking, including the over-the-counter things like herbal dietary supplements and oral contraceptive pills for females. So in Malaysia, you know, many of our patients take a lot of natural, traditional supplements and stuff, which they may not even consider as medication. So when we ask the patients, this is where our pharmacy is very good. They know how to correct and get all the stories about what they're taking from where the neighbor, the jiran, or they're growing it in their garden. Okay. History of co-infections, metroviral disease, Hep B, complications of liver disease, cirrhotic, whether they've been previously treated for Hep C and what kind of treatment they have, what kind of response they have to that treatment, whether they try to promote Hep B vaccination, Hep A vaccination to those who have not received it yet, which of course we don't have in KK for the adults, so we have to ask them to go out and get it, and for other extrahepatic manifestations of Hep C infection. We also need to do the baseline test. Okay, so first the confirmatory test, which first we do the rapid test because most KKs have got the kits, and then after that, if that's positive, that just shows that they have been exposed to Hep C, as we mentioned. So we need to confirm the diagnosis with either a HCV core antigen or HCV RNA, which this one, of course, we have to send up to hospital. So when KKM brought this program down to the KKs and they said, okay, KKs gonna treat sekarang, they forgot to include the hospitals in the discussion. So then the hospital, when we send the sample, oh, kita tak boleh buat ni for you, you're not under us lah, this lah, that lah, this hospital tak buat lah, you kena hantar sana lah. So there was a lot of ding-donging going around. Then we did have a lot of meetings at JKN level with the hospital labs, and then finally now I think each KK, they know which hospital they have to send their blood to get this result back. Otherwise, no results will come back. Then we have to do the full blood count and the LFT. This LFT has to have AST. Most of our KK, we can do LFT already now, but it does not include AST because AST, apparently the reagent is very expensive or something. So we still have to send this AST off to hospital. to get the result. So we have to remember that. So when you have hospital punya darah kena pergi hospital, then it becomes a bit limited, a bit difficult for patients because probably have to come on a certain day because only certain day can take blood and things. So we have to be aware of this scenario, creatinine level. Then we do the FP score or the FIB4 to determine if there is cirrhosis, and if there is cirrhosis, we will refer them to the secondary center. So again, these are scores that we use which are non-invasive, which you can do at KK from the blood results and age and things like that, and we have at our hands. And everything is online in the app on your phone now, so you don't have to hafal and do multiplication and division. Just click and you dapat the result. Okay. Need to do Hep B surface antigen and HIV to rule out whether they have these infections. If possible, ultrasound liver, but it's not necessary anymore. This used to be a limiting factor, kena hantar patient for ultrasound, which makes it difficult for patients to do that test and then to get treatment, and other relevant investigations based on your discretion lah. Okay. And then explain to the patient what's the flow on, what's the follow-up schedule, what they have to look forward to for the next few months. We can get our nurses and medical assistants involved here to do vital signs, to perform the education about hepatitis, you know, how they get it, how they spread it, how they can prevent it and things like that. And for women of reproductive age group, to do pre-pregnancy care for them, to try to advise them to get onto contraception before they start treatment. And if they get onto contraception, then the pharmacist needs to know because there might be drug-drug interactions. So we need to know that as well. So the appropriate contraception is also important. Like I said, the pharmacist, like was presented earlier, they memang will go through the entire drug history of the patient and what they're taking to assess and then to counteract and check for potential interactions and to document any allergies or possible allergies. Okay, what treatment options we have and what's the SOP for this? Okay, previously, before this zaman gemilang for hepatitis C treatment, the only thing available was interferon. Okay, it's a terrible drug to take. It was very long course. In fact, in the beginning when they started, I have one patient who said this was 18 months of treatment, weekly injections plus oral daily ribavirin. So which means every week they have to go to hospital to get this. And that time it was only hospital Selayang, I think in Selangor, that was offering. The cure rate was quite dismal. It's only about 50%. And despite and it's not only the cure rate that is poor, a lot of patients drop out because the side effects were terrible. So I have a patient who is was a drug addict and had Hep C, and he's now he's very cured and very motivated. He actually runs a center for recovering addicts, and he brings a lot of patients from NGO and all that for screening and things like that. And he said the treatment was so bad that he thought he was going to die of the treatment. But luckily he persevered and went on, and he did get converted and all. But he was very committed to getting the new drugs. He was one of those NGOs who went with the government and went to India and initially used to bring drugs for patients to help them out because he said the treatment is so terrible, no drug addict is going to survive that treatment of interferon. Cost also was very, very high. Otherwise, puluh-puluh ribu or beratus-ratus ribu per patient. So the number of patients that were available, that were able to get treatment was very, very limited. So memang very teruk lah for last time. That's why hepatitis C had no treatment basically. So there was then we had pegylated interferon and ribavirin. And then after that we have all these drugs coming in. Their names are even worse than HIV drugs. Okay, you have Paritapavir, Ombitacivir, then you have Sofosbuvir, and their class which is like so easy compared to the others. And we have okay lah, macam-macam nama. But for us in KK we have Sofos and Dakla. So like was shown to you just now, the two drugs that we use. Okay, these are such studies to show that both of them are effective in different versions, different genotypes, and different they tried different regimes, duration, and stuff like that. Okay, so Sofos is a HCV nucleotide polymerase NS5 inhibitor. Most of it is renally excreted, whereas 50% only excreted in the fetus. So in patients with GFR that is poor, they might have to use in portions. But the latest EASL of 2018 says even in eGFR of less than 30 and hemodialysis patients can still use it. It's not affected by cytochrome P450, but again, it still should not be administered with known P450 inducers like rifampicin and St. John's Wort, and contraindicated in patients treated with amiodarone. So that's the main contraindication is amiodarone. The class is again the first approved HCV NS5A replication complex inhibitor with pan-genotypic activity. Okay, and the dose is either 60 milligrams, one tablet, or 30 milligrams, another type of tablet, with a reduced when a reduced dose is needed. It's a once daily dose. It may interact with many other drugs like anti-TB drugs, antibiotics, herbals. It's usually well tolerated with not much side effects. But the common side effects when it's combined with sophos is fatigue, nausea, and headache, which occurs in about 10% of patients. So again, before we start treatment, we already preempt them and tell them that this might happen so that they don't have these fears of things happening. And this is what the pharmacist will help us with. So this is how we used to treat last time, depending on the genotype, whether got treatment experience, treatment naive, which 12 weeks, which ribavirin, without ribavirin. So it's very, very complicated. You look at this also, I want to treat as I will refer to the hepatologist. But now it's very simple. Once you have sophos and DAFLA, as well as non-cirrhotic and treatment naive, it's just 12 weeks of treatment regardless of the genotype. Okay, so following the WHO 2018 guidelines. So simple. Okay, we need to be simple in KK. We don't need to be complicated. So many other things to do, right? So sophos, DAFLA, everybody can take for 12 weeks. So at the baseline, before we start this thing, we do the baseline blood investigations and other investigations we want to do, inform the patient about possible side effects, and emphasize to them they need to be compliant. It's only 3 months, just hang there and make sure you finish the treatment because you can actually cure yourself from hepatitis C. And if they have medications that they're taking, then and with possible interactions, then we have to discuss how to change or temporarily stop the medications. So if there are some drugs that have a potential interaction, we should consider stopping that drug about 2 weeks before starting treatment so that the half-life is gone and it's washed out from the blood like statins. And if necessary, we can replace it with other drugs if it's really necessary. And then adapt the dose depending on what medication they're on. So the one that needs to be adapted dosage-wise is the NACLA. If of our patients, for us in KK, the main people affected are those RBD patients who are on efavirenz, because with efavirenz, you have to increase the dose of the DAFLA. Okay, there'll be a bit more about this later. So again, this is the wonderful app that we have to do. It's so nice to use. You just click, and then you get everything that you want to do. So life is very easy for us now. Okay, so pharmacists will do the drug dispensing and it's it has a very, very important role on the counseling of this. So I think most cases is the methadone pharmacist yang menjaga the Hep C patient because they are related, I think, if you have methadone. Otherwise, whichever pharmacist will probably be well trained into this to make sure that the patient is compliant and all that. So I'm just going through again what I was told just now because this is very important, the role of the pharmacist. We just need to make sure these guys take their medication for 12 weeks every day. And we have to do it in whatever way we can with your diary, with the questioning, with asking them to bring back the bottle, show back the results and things like that. Whatever we need to do. If you have to hold the methadone over their head to give them to relate the methadone to the drugs, also we do that because we really want to get them cured. So the visits will be at first time when you initiate and you start treatment and you talk to them, and then you actually can see them back 4 weeks later to assess on any side effects on any medications that they started taking. So I think every time they come, the pharmacist has to baby to them about what have they started taking in between. We will do some blood investigations at that time and we see creatinine, ALT, AST. Then we see them again at 12 weeks, which is at the end of the treatment, assess on the side effects that they've been having and do a repeat blood test. Assuming in between, of course, we will always tell them that you can come back to us at any time if you have an issue to talk to us if you need any help. And then after you finish treatment, 12 weeks later, they come back for HCV RNA. So we don't do it immediately after treatment, we do it 3 months later. So this is where sometimes we lose our patients because they don't want to come back. But it's fine. I think if you have treated them properly for the 12 weeks, we don't have documentation that they have cured. Maybe you cannot achieve your KPI conversion rate, but you know that you've done the job and you've hopefully treated the patient. So if the HCV RNA at 12 weeks post-treatment is not detected, the patient is said to have achieved SVR, and with no other if they have no liver comorbidities, you can discharge them. You have to see them again. Bye-bye. So that's very, very satisfying, okay, compared to the other patients we have to treat in KK. So anytime they come, we ask about any side effects or any complaints that they have. Ask them again about the medications that they're taking, and then the blood test like I mentioned just now. So the pharmacist will go on about compliance. So again and again, I stress about compliance because it's something you can cure. We need to really make sure they do it properly so that they get cured. Make sure that we check on the over-the-counter stuff that they may be taking, any health supplements, any traditional medications, screen for drug-drug interactions, and then of course to report the ADR stuff because we need to. These are new drugs we're using in Malaysia, so we want to make sure that we pick up all the ADRs that are happening and reassess patients' knowledge about adherence and how to manage and manage stores and things like that. Post-treatment follow-up. if they were not cirrhotic and they have achieved viral suppression, then you can discharge them. You can say, bye, we don't need to see you anymore. But should they have abnormal liver function, then maybe you want to work up to see whether they have other causes of the elevated ALT/AST. Maybe it's a statin that they've been taking or something else. So you might want to do that. If they are cirrhotic and they have achieved suppression, we follow up for hepatitis C cirrhosis carcinomas follow-up. We did 6 monthly ultrasound and AFP levels, fetal protein, and also refer for endoscopy for esophageal varices surveillance. So this one we are following up for cirrhosis because they already had the cirrhosis before the treatment. So your hepatitis C treatment, your DAs do not treat the cirrhosis. They treat the hepatitis C to prevent further damage, but what's already there is there, so you need to monitor. And if they unfortunately do not achieve suppression for whatever reason, then you need to monitor for progression of disease to see if they develop cirrhosis or cirrhosis worsens. And possibly if we have alternative treatments coming into the market, we can consider them for treatment. Okay, if you have a non-cirrhotic patient who also has HIV and co-infection and is treatment naive, never had any treatment before, then these people with HIV and Hep C are at risk of having a more rapid disease progression and developing hepatic decompensation than someone who only has hepatitis C, even if the HIV treatment is successful and the patient is having an undetectable viral load. So you consider, oh, that means the HIV is okay, right? It should be okay. But even then, these patients have a higher risk of further damage to the liver than patients who don't have HIV. So these patients should be prioritized for hepatitis C treatment. And if they are treated properly, the treatment outcome with the direct-acting antivirals is comparable to treating someone without HIV. So these are safe and effective for people with HIV and Hep C, and there's no need to consider them a special population or a difficult to treat population. In other words, they can be treated at KK lah. Basically, they can be our babies as well. The problem is that there are drug-drug interactions between the pan-genotypic HCV regime, that's a DACLA, and your ART. So we need to check for this before we start the treatment. And for sulfurs, we don't need any dose adjustment. For DACLA, if the patient is on inanavir, azathionavir, or ritonavir, which we don't do in KK, so this is at hospital, we need to decrease the dose of DACLA from 16 to 30. But our patients who may be on efavirenz or nevirapine, we need to increase the dose to 90. Okay, so same. Yeah. Let's see. Yeah, the Hep C rapid test is like a screening test. It's a test to show that the patient has been exposed to hepatitis C infection. We need to know whether they are actively the Hep C is active in them or not. Remember the Rupi slide, the slide where some people, it goes up and it comes out and then it's down forever. These people you don't need to treat. But some people, when the second graph showed the thing going up and straight like that, these are the people we need to treat. So we need to do either the HCV RNA or the Hep C core, because either one shows you active infection, whichever one our labs are doing. And only if that is positive, only these people need to be treated. If you don't have that, you need to treat them. Yeah, that's clear. So back to the drug doses. So our patients in KK will need to be on 90 milligrams of daclazivir. Daclazivir comes in 60 and 30. 60 was available in the KK, 30 was preserved preciously by the hospitals who didn't want to lend us. So although we know that people with HIV and Hep C need to be treated fast, we just couldn't get Dacla 30 given to us at the KK. So we had patients who were waiting, and then we had to refer them to Sungai Buloh, and then it was a pandemic as well, so it was difficult for them to go. So there was a lot of delay in these patients just because we couldn't get that 30 milligram tablet. So, but I hope now we won't have that issue. I don't know. We're gonna have that issue now. Okay, so now we can get ready. So hopefully that problem won't happen. So that was quite traumatic because we had patients who had C and HIV, and we just couldn't get them on treatment. Okay, this is basically just showing you all the drug interactions between the drugs that we have, Dacla, of course, and the others, and the other ARV treatments. We don't have other ARV treatment, we don't have other Hep C treatments, so that's good in the slide. And then this slide just to make you all wake up in case you all fell asleep. Okay, and this is okay. because many of our Hep C patients are drug addicts or were drug addicts, we need to look at all the occupational or illicit drugs, recreational or illicit drugs that people use, okay, like methadone and cocaine, cannabis, and the rest of it. If you look, sophos can be used with everybody, so it doesn't matter. This slide unfortunately doesn't have anything about DACA, but sophos is okay, so I believe DACA is okay lah. So anyway, we don't have any other choice, so we still give them this. We always, of course, obviously, we will tell our addicts to not take anything while they're on treatment, but that is a different story by itself. So at least we know it's fairly safe. So just to remember that the APRI is showing us the AST to platelet ratio, which is why you need to send off the AST to be able to start treating the patient. And a lower APRI score can rule out cirrhosis. A higher APRI score probably shows there is cirrhosis. The FIB-4 is another non-invasive estimate of liver scarring. Again, we have auto calculator available, taking into account patient's age, AST, platelet count, and ALT levels. So when we do documentation for our patients on DAA, we want to see how many of our patients have sustained virological response after 12 weeks after treatment. We want to look for safety assessment to see the people who discontinue treatment because of, for any reason, especially because of safety related, that means they had bad side effects or something like that. If they defaulted because they went back to their drug habits and they didn't come, that's a different story lah. But for those who stopped because of adverse drug reactions, we need to know. And we need to see the incidence of abnormal events, adverse events, and laboratory abnormalities when during treatment. So patients who have got sustained virological response is very important because these people have fewer Hep C related complications as the years go by. So this is a 10-year cumulative incidence of things happening to patients. As the red group is the people who achieve suppression, the blue is those who did not have suppression. All-cause mortality is much lower. Liver-related mortality or transplant is very much lower. Hepatocellular carcinoma is lower, and liver failure is lower. So some of these patients may have been patients with cirrhosis before we started treatment, which is probably why they were here. But if you see the difference between those who did not achieve suppression and those that did over 10 years, it's actually much lower. Yeah. So they followed up 85 patient for 8.4 years. Yeah. Okay, that's the last slide. Any other questions? No other questions?
Hi, Doctor. Can you
what
hear
I
me?
want to say is that this is something that we can do that can benefit a big part of our population, of our very high risk population who is very hard to treat, but we can do it at KKs. In fact, initially when they started this program and they said, okay, kita buat, they launched it at one of the national hepato gastro conferences, and then we in the KK were like upset lah, like okay, they want to send some more culture to us as usual, everything hantar kat KK. But when you look at it, it's actually the place for us to do it. We are the ones to do this job because these patients are finding it very difficult to go to hospital. And like I said, it is really very satisfying when our patients get treated. So many of my methadone patients, because if you notice in our drug addict population, we have much lower rate of HIV among them than hepatitis C. When we first started methadone in Taman Medan 12 years ago, we screened everybody because we're supposed to screen. So HIV sikit je. I think I have 4 or 5 only HIV co-infected HIV methadone patients, but I have lots and lots of hepatitis C patients. We screen and then that's it. We can't do anything for them because they couldn't get interferon and stuff. So we just monitor them yearly with ALT, and then you see the thing going up, but you still can't do anything. Whereas the HIV patients, we managed to put on treatment. So when this thing came on, all those patients that we screened many years ago, we managed to get them on treatment, and most of them did very well and got treated. So it's like very satisfactory. So it's something that's really good for KK to do. So I hope those of you who haven't really started screening will do so. At Taman Medan, I got no more people to screen because I already screened all my IVDUs, all my methadone patients, all my HIV patients, all my STI patients already screened. So the risk factor for Hep C is much less than HIV. So now we just do like opportunistic screening here and there, but the pickup rate is quite low. Yeah. So those of you who haven't grabbed all these patients in your area, please do so. The tablet cannot potong kedua. the dakla cannot auto do. That's why you start. You have to wait for the 30 milligram tablet to come along. The anti-HCV kit ada for everybody ke now, Doctor? No? The one that we had all expired, that we got from the fine. Okay. I have to check with the Unit HIV and then they'll let us know. We had a lot last time, and then finally it expired. The ones with sustained suppression with liver problems, probably you just keep on monitoring them 6 monthly forever and ever lah, because they have, unless it gets back to normal, if the liver function goes back to normal, then you can probably discharge them. But if not, then you need to monitor to see whether it's getting worse or better.
Ada soalan doktor dari Qcom atau apa?
Mana? Apa ni? Dah kata dia dah.
Kan kita cek dengan audio tadi.
Saya dia cakap ni. Dia bawa this one, is it? Whether you have to wait for the result. Memang kena tunggu result. Nak tengok patient aktif ke tak.
Kan dia ada nak tanya lagi tadi. Tapi suara dia tak keluar dah.
Oh, when can we start screen then? Wah, Cik Hari dah excited. Tunggu Manu dengan Jaya kasih kita tu hepatitis screening kit dululah. Dia fikir dia akan cari. Kalau ada dah, you boleh start. Ubat available already kan? Boleh dapat already. In fact, there was so much of ubat you had to pulangkan because it was all expired. Some of the pharmacies very cekak, dia pandai-pandai bagi ke hospital get treated. So I don't think it was wasted, but we didn't have any more that time, but can get lah.
Hi, Dr. Vicky. Can you hear me?
Duduk glamour tu dia studio.
Ada, dia dengar tak soalan dia?
Mana dia soalan dia? Dia cakap tu.
Hi, Dr. Vicky. Can you hear me? Hi. Can anyone hear me?
Yes, I can hear you.
Hi, Dr. Vicky. Sorry, I think because I can't really hear the some of the audio. But I just want to ask actually, do we have to really wait for the core antigen or HCV RNA confirmatory test to start the treatment? I just want to know that part.
I think Dr. Vicky cannot hear you.
Oh.
I cannot hear the question.
Betul, hospital ni. Sini.
Can you? Hi. Can anyone hear me?
Can hear.
Can hear.
Yes, yes.
Actually,
Type right.
sorry.
But I think Dr. Vicky cannot hear. Just need to wait.
Yeah, now I
They-
can hear.
now they can. Yeah.
Okay. Hi, Dr. Vicky. I'm actually Dr. Fabian here from Klinik Kesihatan Taman Ehsan. Okay. I just want to ask. I think actually I typed that question before, but I can't seem to hear the answer. Sorry about that. It's just that when we do the HCV rapid test, if it's positive, do we have to wait for the confirmatory like RNA or Hep C core antigen to start treatment? I just want to confirm that
Yeah,
part.
yes, you have to wait because the HCV that we do the rapid test, it just shows that the patient has been exposed and infected by Hep C before. But we don't know whether they are under the 15% who managed to clear off the infection from result. Remember the natural history, 15% can clear off, they don't need treatment, or whether they are under the 85% who need treatment. So we do have to send off either the HCV RNA or the HCV core antigen, whichever one is available, to confirm that they are actually having active hepatitis C infection.
Okay, thank you, Dr. Vicky. Thank you.
There were patients during the PINE study that we did who had Hep C positive, and then when we sent them for the further testing, they were negative. So it is important to do it.
Okay, thanks.
Any other questions?
Question dalam chat box tu.
Okay, sorry. Which question? Dah jawab tadi dah? Which question yang I boleh jawab?
Start screen and record. Sudah.
Itu saya cakap dengan Dr. Khairi, sabar dengan fikir dia kena bagi dulu.
Oh.
As soon as you get the
Kalau 60 mg tak ada, kita boleh patah dua ke? 30 mg tadi kata maybe we don't have the
tak pecah. That's the problem. This drug tak boleh dipotong.
noted. Okay, the next question by Dr. Siti Fatimah. How long do we monitor those with impaired liver?
Okay, I dah jawab dah. Okay, jawab lagi sekali.
Dapat dengar lah. Itu.
LFT, I guess you need to follow them up 6 monthly to see whether they're progressing and whether you need to assess what's happening with them or do further investigations. If they have become normal, then I guess you can discharge them. Any other questions? Okay, if there are no other questions, thank you very much for listening. I'll pass over to the university again. I'm back. Where? Currently screening patients for hepatitis C to hospital. Can we send? Oh, you're doing. I think you need to get the result back first, the HCV antibody result first, and then only send off the HCV antibody. Because I don't think the hospital is reflexly testing. They're supposed to, but hospital is a different category of people altogether. So you can request, I suppose, in the form, please proceed to HCV RNA. And if they are nice, they will do it for you. Otherwise, when you get back your HCV antibody positive, then you might have to retest again. Yeah, there will be a delay in treatment, yes. But we will understand that most of our patients have been having Hep C for years and years and years. So I guess it's better now that we are starting. Actually, it's very important we get the rapid test kit first because that will really help to speed up things.
Okay, thank you, Dr. Vicky, for the informative and interesting talk. Okay, before we proceed with the next presenter, we can take 5. Then we start again at 10:30 boleh? We break first. We start again at 10:30, okay?
Malaysia, we have more than 400,000 people suffering from hepatitis C. It is a major public health concern.
然后就经过医生的讲解给我听了，然后他说这个肝炎病是很严重的，它会肝硬化，然后就变成 cancer 就死了的这样子。然后有一个小小愿望啦，就是说看这里啊能不能变成做那个民宿啊。可以来这边休息，然后有自己的菜罢了，就可以自己炒自己煮。但是不知道这个愿望能成功吗啦
？Hepatitis C is basically a virus. Primarily, it will affect your liver.
It's sometimes called the silent disease because people with the disease don't know they've had the infection. And it's only many years later that some of them develop cirrhosis, liver cirrhosis, or liver cancer.
然后我就问他说：“这样有没有药可以医治？”医生就讲有咯。然后第一批药，医生给我是和打针的啦，药源刺跟打针的。
The treatment in the past is so, well, I would say horrible to a certain extent and perhaps toxic because we were dealing with the treatment like interferon before and ribavirin.
And the treatment was also for a very long duration and the cure rate was also very low.
没有吃了这个药啊，5个月，医生在 test 啦，抽血 test 了，说我对我这个身体没有效果啊，他说我的 virus 还有存在啦，在我体内，只是医生跟我讲说，就是等新的药进来罢了啦，外国的新药进来马来西亚，然后就等，一等就是等超过已经10年了。
There's actually a revolution treatment in hepatitis C, the DAA.
When the DAA came in, that was sometimes in 2015, I think, to Malaysia. And it's a major breakthrough.
But the issue is the cost. It's very expensive. And not many people can have access to the treatment.
DNDi, or Drugs for Neglected Disease Initiatives, is a non-profit organization and it works to get treatment for neglected population. When DNDi was studying the DAA landscape, they came across remdesivir. And we also found out that an Egyptian company, pharmaceutical company, Farco, had done a clinical trial using remdesivir and the results were very promising. Following this, DNDi, together with the Ministry of Health in Malaysia and the Ministry of Public Health in Thailand, conducted a clinical trial on the safety and efficacy of remdesivir. We had a 97% efficacy, which made it comparable to the other DAAs. And these are better tolerated by the patient, it has fewer side effects, and it had a better cure rate. A project of this magnitude and complexity requires a number of partners.
So together with agencies and other societies, we can make the impossible possible.
For all of us who have been involved, we're extremely excited that now there is a treatment option, an affordable treatment option for people with the infection.
Now we can tell the patient now, I have the treatment for you right now because you all have been waiting. We also been waiting, but now we have the treatment for you. Almost 100% of those patients who've been treated on this clinical trial clear the virus.
Well, the targets of WHO is to end hepatitis C in 2030. The question is how to achieve that goal.
Our part now is that we should try as much as possible to get as many people as possible to be screened, and those who are tested positive should be accessed for treatment.
开始吃第二批新药的时候啊，吃3个月，3个月，但是好消息来说，我的肝病好了，我的肝炎啊已经降到0了，没有了。然后我就也有很开心啦，知道说我的病这个疾病啊，肝炎病已经好了嘛。然后他们也妈妈也跟他们说他 OK 了他。
When I reflect back, it could be like a magical journey to me. No doubt that we have challenges, we have lots of problem issues along the way. This is worth an effort. This is so fulfilling and gratifying. We were going to walk through this journey together until the finishing line.
The whole concept.
Okay. Before the next presentation begins, allow me to introduce the next presenter. This is Mr. Chung Han Yang, Pegawai Akses dan Kaunselor Pendaftar. Mr. Han Yang adalah seorang kaunselor berdaftar dengan Lembaga Kaunselor Malaysia dan pernah bertugas di Klinik Penyakit Berjangkit Hospital Sungai Buloh. Beliau sekarang bertugas dengan Drugs for Neglected Disease Initiative DNDi, iaitu sebuah NGO yang membuat kajian ubat untuk neglected disease dan Hep C. Without further ado, I would like to welcome the next presenter to deliver the presentation.
Hi Hanya.
Hi Dr. Vicky. Thanks Dr. Jaya and PKD Petaling sebab menjemput saya. I think I would speak in Malay sebab I prepare dalam bahasa Melayu. So hope it's fine untuk PKD, boleh Yeah. So terima kasih banyak-banyak sebab menjemput saya untuk Dr. Jaya. I think terima kasih sangat-sangatlah. Saya nampak passionate team dekat PKD Petaling bersama dengan PKD lain dekat Kuala Langat dengan Gombak. I'm very interested and amazing to see sebab kita COVID sekarang semua buat webinar online. So the reach the training kepada orang akan dapat kita reach out ramai lah kepada semua orang dalam masa yang singkat. So just before I start, boleh nampak saya punya full screen ke? Ada tak nampak apa-apa gangguan tak? Tak ada Okay, so I will teruskan. Kalau ada apa-apa gangguan, just beritahu saya lah. So tajuk yang diberikan saya masa singkat 45 minit. Saya cuba akan bincangkan dari segi strategi pencarian kes hepatitis, bagaimana kaunseling, program kesedaran dan kerjasama dengan NGO boleh membantu kerja anda dekat klinik kesihatan dan juga dekat PKD lah. Ramai daripada anda daripada PKD. Dan terima kasih doktor tadi introduce saya. So sedikit tentang my background. I just work for HIV work for quite some years. Sebelum sekarang saya move dekat hepatitis C lah dan bersama dengan DNDi. Ini dulu saya kerja dengan Sungai Buloh dan Majlis AIDS Malaysia juga. So tentang sesi saya pagi ini, saya cuba memberi pendedahan kepada anda semua dari segi 3 bahagian, iaitu pencarian kes Hep C, jurang yang utama, the major gap, pencarian kes pendekatan individu iaitu dengan kaunseling HCV, dan juga satu lagi ialah program kesedaran dan komuniti lah, bagaimana kita boleh mencari patient-patient kita macam Dr. Vicky dan tim cakap tadi. Ramai sudah dirawat dan tetapi ramai juga yang kita perlu cari mereka sekarang. Okay. So pencarian kes Hep C, I think tadi Dr. Tim tadi sudah bincangkan kenapa untuk hepatitis C is very important for us to fokuskan, sebab strategi negara dan sedunia sekarang adalah kita mempunyai global target by 2030, kita perlu merawat sebanyak yang mungkin, diagnose 90% of the Hep C chronic and treat 80% of them. 80% kita kena rawat mereka, dan kita tahu ini strategi sekarang tengah di-update. So the target negara-negara seperti Malaysia sudah committed untuk kita rawat patient Hep C kita by 2030. Tetapi anda boleh lihat ini data yang terbaru 2019 di Western Pacific region di mana Malaysia berada, kita hanya mampu screen 25% of our patients saja buat masa ini seluruh Western Pacific region lah, dan juga rawatan hanya 10% daripada mereka yang perlu rawatan sudah dirawat. So kita nampaknya ada banyak kerja lagi yang kita kena kerja untuk mencapai this target yang set up by the World Health Organization dan juga negara-negara yang committed lah. So anda lihat juga tadi Dr. Vicky ada touch tentang National Strategic Plan. Actually in National Strategic Plan kita boleh nampak setiap tahun kita lebih kurang diagnose 3,000 orang setiap tahun. Cumulative antara 2003 ke 2019, bila I tengok data, is 30,000 patient. So 30,000 orang sudah di screen. Kita tahu status Hep C dia. Tetapi kalau kita lihat anggaran yang pernah dilakukan oleh pakar research kajian, mereka menganggarkan kita ada 300,000, lebih kurang 300,000 lebih orang yang hidup dengan Hep C di Malaysia. Walaupun the number mungkin lebih kurang lah, mungkin 100,000 ke 200,000, tapi kalau kita letak target 100,000 pun anggaran dia, kita masih jauh lagi. We need to find another 70,000, another 100,000 patient, di mana patient Hep C ini. So antara dan juga satu fakta lagi, antara the past 2013 sampai sekarang, 2013 sampai sekarang, kita hanya jumlah sekitar 13,000 pesakit di Malaysia dirawat saja. So nampaknya berbanding dengan 30,000 ni betul ada yang meninggal dan sebagainya, tetapi ada ramai juga yang tercicir. So di mana mereka? So kita kena cari, dan itu sebabnya tugas anda di frontline PKD dan KK, inilah tempatnya. Kalau dekat hospital, kita tak mungkin akan mencapai target ini dan ramai pasien kita akan mati, akan meninggal dunia sebab mereka tak dapat rawatan. So bila kita lihat ini juga daripada sektor HIV dan Hep C, kita nampak PWID memang majority, tetapi ada juga sexual transmission is catching up. Jadi kita punya, bila kita buat strategi, buat saringan Hep C, kita kena lihat bukan saja kita target PWID, tetapi kita kena juga macam Dr. Wiki and team kata, kita kena screen our STI patient, kita kena screen our general population yang sexually active. Dan ramai daripada mereka letak tidak diketahui. So we know mungkin ini isu stigma lah. So mungkin they are sexual transmission, they are drug users, kita tak tahu. Tapi ramai daripada mereka yang kita tahu dia letak tidak tahu. Tattoo pun there are some. So we need to focus on that also. And I think ini senarai mungkin untuk rujukan anda. I think ramai daripada anda tadi sudah banyak penceramah sudah diberi siapa yang perlu disaring, so saya takkan go through in detail lagi. So just to let you know, a lot of these are our HIV punya key population. Di Malaysia punya konteks, Hep C jangkitan banyak berlaku di kalangan mereka yang key population seperti yang MSM, sex worker dan juga drug user lah, pengguna dadah. So ini I just reiterate apa yang dikongsikan oleh pembentang tadi, penceramah tadi. Pengguna dadah suntikan, saya rasa bagi saya, I think kita kena fokus juga bekas atau semasa, because not just our methadone patient yang ada juga, tetapi in some of the patient yang I dengar pakar gastroenterology ada kata a lot of them are many years ago dia guna dadah, dia kongsi dadah, tapi lepas tu dia sudah tak guna dadah, so they don't show up in your methadone services. Tetapi where are they? So they are basically the general population. So saya rasa we have to find a way to see how we can shape our message to cari orang yang sudah bebas ataupun bekas pengguna dadah inilah. So saya rasa itu adalah golongan yang penting juga sebab they will be a big group saya rasa. Satu lagi ialah MSM. So lelaki yang ada hubungan seks dengan lelaki. Bagi program yang ada biasa dengan HIV, saya rasa you are familiar with the terms. So tetapi secara amnya the traumatic sex seperti chemsex, fisting dan sebagainya, ini adalah sesetengah praktis yang kita punya patient MSM selalu praktis. So it's a area yang kita kena fokus juga. So in your HCV service delivery, perkhidmatan anda bukan setakat sahaja perlu fokus kat drug user. So you need to start talking also benda-benda yang sensitif seperti seks, hubungan seks dan sebagainya. Dan mereka yang hidup dengan HIV sudah tentu, I think you all do baseline. So you need to make sure all the ARV patient yang under you, make sure you make a review mereka sudah dapat Hep C atau tidak. Sebab I think Hep C, PL-HIV co-infected patient lebih kurang 10% every year lah. So let's say you punya klinik ada 20 patient HIV. Mungkin you ada 2 atau 3 orang adalah Hep C positif yang mungkin perlu susulan rawatan. Dan last kali saya rasa dari segi strategi jurang kita, saya rasa Dr. Wiki dan sudah berkongsi dengan anda kenapa walaupun kita semua push patient kepada klinik kesihatan nampaknya memberi banyak kerja kepada anda, tetapi sebenarnya all our patient yang saya tunjukkan tadi, mereka perlukan anda sebab these are the place where the people who inject drugs, mereka yang daripada community, mereka hanya boleh dapat rawatan kalau dia berada di community, decentralized in primary healthcare clinic. Kalau dia berada di hospital base, saya rasa kita sampai 2030 pun kita baru treat mungkin 10,000 orang. Tapi lain-lain semua akan meninggal dunia sebab Hep C lah. So itu sebabnya sangat penting kerja-kerja anda dekat front line. And also a lot of them are hard to reach, PWID, MSM, sex worker. Ini adalah mengikut Datuk Dr. Razi, that will be our future, our onwards going punya isu yang kita kena hadapi lah dalam program hepatitis C kita. So then saya touch ke bahagian kedua, pencarian kes hepatitis C dengan melalui counselling hepatitis C. Saya rasa pencarian kes ini bukan sahaja kita buat screening, tetapi juga your daily interaksi dengan your patient in your clinic. So this is very important lah. So saya beri satu scenario case. Contohnya scenario case yang ini biasa wujud. 47 tahun Encik Amir berasal dari Felda. Si Panduk saya reka lah mana-mana Felda, aktif guna dadah suntikan sejak umur 20 tahun. So very young, usually mereka daripada Felda, dari kampung dan sebagainya. Kita sentiasa ada dengar cerita-cerita sebegini. Kini mengambil metadon di KK, stabil dan rawatan metadon pada 5 tahun kebelakangan ini. Tetapi dan juga mempunyai kerja yang tetap lah. So dia kira stabil. Tapi sepanjang follow up KK klinik metadon, beliau tahu bahawa dia menghadapi HIV dan Hep C, tetapi enggan mulakan rawatan selanjutnya. Selalunya mereka banyak alasan. I'm sure a lot of the doctors dan pharmacists dan MA, you all know alasan-alasan mereka yang pelbagai, tidak bersedia, takut atas kesan sampingan dan sebagainya. So doktor beliau jumpa meneruskan follow up visit seperti biasa. So your methadone services, you masih jumpa dia lah dalam annually ke atau setiap 6 bulan macam tu. So apakah yang boleh dilakukan dalam counselling rawatan anda kepada Encik Amir ini? So ini something for us to fikir. What can we do as healthcare worker? Macam the pharmacist tadi ada cakap, very important, kadang-kadang you kena buat counselling untuk your pesakit metadon juga. So this is where the entry point nampak. Case Amir ini kita nampak dia sebenarnya menggunakan metadon. So dari segi cascade of care of hepatitis C, prevention itu, pencegahan itu kita dapat cegah daripada dia jangkit kepada orang lain. Tetapi malangnya dia punya dari segi confirmation dia, dari segi cure, sembuhkan dia dari segi hepatitis C, cascade of care ini kita tak dapat diteruskan sebab patient ada banyak alasan dan banyak isu di dalam kita engage dia dalam rawatan hepatitis C ini. Dan itu sebabnya dalam segi counselling hepatitis C, mengikut the Substance Abuse and Mental Health Services Administration US, mereka mensyorkan saringan dan penilaian secara rutin kepada semua pesakit dimulakan hepatitis C. So proactive approach. Saya rasa di sini the key is kita mengambil satu satu pendekatan yang proaktif supaya kita make sure all our especially our methadone patient dalam klinik macam Dr. Vicky dah treat semua. So ada KK lain dekat mungkin Kuala, Langat dan juga Gombak dan Petaling juga mungkin yang perlu. So this is where you boleh lihat semula your record patient dan cari mereka yang Hep C positif untuk anda start buat program dengan mereka lah. Start do active counselling for them. So counselling membantu pesakit kronik ini membuat keputusan mereka tentang rawatan dan juga sokongan yang diperlukan untuk menguruskan risiko mereka dan juga kelebihan berkaitan dengan rawatan. So dalam counselling saya rasa selain daripada kita buat test untuk dia confirm dia positif dan sebagainya, kita juga memberi dia satu sokongan. Kalau kita lihat counselling punya definisi mengikut WHO punya guideline for sexuality related communication, counselling ini adalah konsultasi yang sistematik. Anda sebagai doktor, paramedik, ataupun mereka-mereka yang buat testing lah untuk patient kita, di peringkat kesihatan prima anda boleh memberi sokongan dari segi emosi, psikologi dan sosial yang mungkin mempengaruhi mereka punya keputusan mereka buat tentang diri sendiri punya kesihatan. So if you do a little bit more support for them, counselling them, mungkin anda dapat menarik mereka untuk come forward for rawatan Hep C. Sebab orang yang disahkan positif Hep C sebenarnya dia ada beberapa pilihan lah. Sama ada dia dirawat, melambatkan ataupun membuat keputusan tidak merawat. So kita respect setiap individu punya reason. Tetapi some of the contoh dalam counselling yang you boleh lakukan, you boleh tanya dia apakah tentang apakah dia nampak kebaikannya atau tidak. Apakah kebaikan dan apakah kekangan. Sebab some of the patient mungkin dia tak tahu sangat tentang ubat terbaru yang wujud, because a lot of them have this story yang lama yang patient drug user banyak mereka kongsi sesama diri. So macam Dr. Razi dan juga Dr. Vicky akan kata, the drug previously we use is very toxic, macam interferon dan sebagainya. So mungkin mereka ada sebab-sebabnya yang dia tidak faham tentang ubat itu dan sebagainya. Dan juga antara isu you boleh gunalah biar dia banding kebaikan dan keburukan dalam perbualan, dalam counselling anda untuk mereka yang hidup dengan hepatitis C ini. Dan at the same time juga anda boleh tanya mereka lah, bilakah dia nak buat rawatan kalau bukan sekarang. Okay, so all this slowly you boleh cuba yakinkan dia dan apa yang dia inginkan sekarang dengan rawatan dia. So mungkin dia sekarang hidup dia sudah stabil, dia nak rawatan. So this is the right time mungkin you offer. But mungkin some of your colleagues yang dulu dia tanya MO, dulu tanya dia masa dia ambil metadon, dia tak sedia lagi. Mungkin that's 2 years ago. Tapi sekarang mungkin dia sedia. So I think the counselling perlu constant, perlu sentiasa kita cuba untuk meyakinkan patient kita. Dan anda boleh lihat dari segi guideline ini yang diberikan oleh the US punya guideline, dia mengasingkanlah beberapa kategori. Ada yang mereka yang tiada, sudah kita tahu dia negatif, so apa yang perlu dilakukan? Counselling approach dia. So I just put up here for you to consider, but main thing adalah di semua mereka yang negatif Hep C, mereka yang positif Hep C yang sudah bersedia ambil ubat, mereka yang positif Hep C yang tidak bersedia ambil ubat, semuanya kalau boleh anda cuba bincang pasal risk reduction, just like our HIV work. Kita bincang pasal bagaimana dia boleh mencegah Hep C, bagaimana dia boleh mencegah HIV. So in the same case for all these patient yang datang for testing dan juga yang pernah test positif, kita mesti make sure we discuss about the risk reduction plan dengan kita punya patient. Dan kalau boleh kita encourage mereka through inform the Hep C punya treatment, what's the latest one dan sebagainya lah. So semuanya dekat sini bersentuh tentang create risk reduction plan. So saya rasa itu adalah salah satu topik penting dalam counselling Hep C dengan patient anda. Okay. Dan farmasi ada keluarkan the protocol untuk MTAC. So ini MTAC protocol, dia boleh memberi anda serba sedikit tentang apa yang boleh anda bincang dengan patient you dalam counselling hepatitis C kepada patient anda. Tetapi ini hanya I nampak dia more to drug, more to the medicine itself. Tapi saya rasa banyak isu-isu psikososial sebenarnya yang mempengaruhi seseorang itu membuat keputusan ambil ubat. So ini adalah benda-benda yang sebagai pharmacist, paramedic dan doktor, you have to touch about this area juga supaya anda boleh lihat kenapa the patient seperti Amir yang tidak ingin ambil ubat. So kita boleh lihat kalau kita lepas saya cakap tadi tentang all this cara, I think one main part yang saya rasa dia tidak ambil dari segi senario case ini kita boleh nampak sebenarnya masa yang dijangkiti oleh case ini mungkin sudah lama. Okey, jadi kita boleh lihat tindakan segera kita sebenarnya perlu. Because in Selangor area, I ada banyak bincang dengan NGO seperti Insaf Muni. Contohnya dekat Semenyir, I think the whole kampung, a lot of their friends yang outreach worker yang juga merupakan bekas pengguna dadah, satu kampung kebanyakan sama umur sudah meninggal dunia. Sebab Hep C ini mereka sudah ambil dadah dari awal, sudah dijangkiti Hep C mungkin pada umur 30 tahun, dan sampailah umur 50 tahun sekarang sudah sirotik dan juga kanser. So this is a huge problem. Jadi sangat penting kita ambil tindakan yang segera untuk patient anda di lokaliti anda lah. And at the same time saya rasa counselling ini is very patient centric approach. Jadi kita perlu memberi counselling supaya kita memahami apa concern yang dihadapi oleh Amir. Apakah isu, kenapa dia tidak bersedia, kenapa dia takut kepada kesan sampingan, sebab some of the issue di kalangan pengguna dadah adalah cerita rawatan lama, macam saya kata tadi. So ini adalah benda-benda yang kita kena slowly explore, kita kena meneroka. Bukan setakat saja kita tengok okey dia cakap dia tak bersedia, dia takut, okey jom kita leave dia dekat sana. Saya rasa kita kena buat lebih untuk kita cuba counselling dia, tanya dia apa sebab dia bimbang, dan supaya kita boleh cuba yakinkan dia. Sebab sekarang, dan juga satu benda lagi yang kita nampak sekarang, proses dia sangat mudah. 5 years ago mungkin macam doktor dekat KK susah untuk yakinkan patient because there's no medication, long waiting time. Kalau you pergi hospital pun dia mungkin tunggu lama sebelum you dapat you punya ubat, because the waiting list is long. Hospital punya proses pun kena ambil darah, lepas tu kena balik, kena check your appointment, lepas tu kena follow up, check you punya hati punya sirotik ke non-sirotik, lepas tu barulah dia akan tengok you boleh mula ubat ke tidak, sesuai ke tidak, kena check genotype. So sekurang-kurangnya 6-7 kali pergi ke hospital, patient pun belum dapat ubat lagi. So bayangkan all our patient yang drug user sudah tentunya mereka rasa pengsan dan a lot of them give up. Itu sebabnya walaupun kita ada 30,000 orang yang kita diagnose Hep C, kita hanya boleh mampu rawat 15,000 sekarang. Because dan ramai daripada I dengar cerita-cerita rata-rata KK macam Taman Medan dan tempat lain, patient sudah kita habis treat. We have treated all the patients in the facility, hospital dan juga KK. But we have a lot more patient dekat community. Di mana mereka? So saya rasa inilah di mana kita boleh memudahkan mereka dengan memberi rawatan dan juga saringan di KK. Dan kalau KK anda tidak ada, anda kena tahu di mana KK yang terdekat sekitar anda yang boleh dirujuk. Ini adalah maklumat yang sangat penting. Jangan kita simply buat surat rujukan, pergi terus ke hospital. You buat macam tu, yes, you are not wrong, tetapi your patient won't go because it's too far away from them to pergi ke tertiary hospital, dan waiting list di hospital pun panjang, lebih panjang. Mungkin KK yang berdekatan boleh buat rawatan ini untuk patient anda lah. So itu saya rasa salah satu cara di mana sebagai you punya di KK anda, how you can use counselling untuk cari patient Hep C ataupun untuk cari patient yang belum mula rawatan sebab mereka adalah patient lama yang sudah tercicir, ataupun kadang-kadang kita tukar doktor turnover pun ramai, so kita lupa follow up dia punya file, record dia tebal. Sebenarnya the first page ada Hep C positif, so kita kena follow up untuk case-case macam inilah. Okay, dan itu untuk drug user. Saya rasa in our practice, kita nampak juga macam itu hari I baru jumpa Dr. Nurul, dia pun ada kata baru-baru ni dia start satu patient MSM on Hep C DAA, ubat rawatan Hep C. Saya rasa men who have sex with men semakin meningkat kes-kes yang MSM menghadapi jangkitan Hep C lah. So in some of the local data, macam kita baru-baru ni ada satu DNDi ada buat satu discussion dengan Thailand. Kita nampak explosion of Hep C epidemic among a HIV positive MSM. So ini adalah number yang meningkat lah kalau berbanding dengan tahun-tahun sebelum ini, stabil saja. Tapi anda boleh lihat the Hep C number in the past few years suddenly meningkat lebih, meningkat. Dan saya rasa Malaysia pun walaupun kita tak nampak lagi banyak MSM, tetapi the number is coming. So saya rasa ini adalah something KK we need to prepare ourselves to see how we can screen the KK. Dan untuk mereka yang daripada key population, saya rasa panduan HIV Prima KKM 2015 ada mengatakan elemen counselling yang berkesan, kita bukan setakat buat saja testing, tetapi kita juga perlu memberi counselling kepada pesakit-pesakit ini. Jadi non-judgmental pendekatan ini adalah tidak menilai. Walaupun mereka buat benda yang mungkin aktiviti mereka tidak begitu sesuai dari segi agama dan juga kita punya fahaman dan juga kita punya ada daripada anda mungkin tidak setuju, tetapi pendekatan kita bila kita memberi perkhidmatan counselling atau perkhidmatan perubatan kesihatan kepada mereka, kita perlu mengambil tindakan yang profesional dan juga non-judgmental, tidak menilai. Jadi kita treat mereka sebagai manusia yang perlu rawatan, perlu jagaan daripada kita. Sebab treating HIV you save life. So second thing ialah menjaga kerahsiaan. Di tempat anda KK usually is very sensitive. Orang mungkin datang daripada komuniti yang sama. So dan living nearby dan sebagainya. So as a healthcare workers yang menjalankan HIV program dan juga Hep C program, because you touch benda-benda yang very sensitive, for example like MSM, like drug user, transgender dan sebagainya, sex worker. So menjaga kerahsiaan itu adalah sangat penting. Jangan sekali-kala kita kongsi dalam WhatsApp kepada kita punya kawan walaupun mereka healthcare workers, tapi dia klinik lain. Kita kena berhati-hati untuk kongsi cerita-cerita, story-story like this when we see our patient in the clinic lah. Right? Empathy ataupun kerahsiaan, kita kena make sure kita bila bincang ataupun dengan ahli keluarga dan sebagainya, jangan sekali-kala kita keluarkan maklumat peribadi patient kita. So that is the very, very important benda yang kita kena stress dalam perkhidmatan HIV dan Hep C kita dan juga metadon. Empathy kepada klien. Saya rasa mendengar, that's why in your KK, I know metadon kadang-kadang is daily kan. Dia datang sekejap, dia pergi. Datang sekejap, pergi. Tapi you sebenarnya kalau you boleh lihat, you boleh strategize among the maybe 20 methadone patient, 30 methadone patient yang you ada setiap hari. Ada beberapa orang yang mungkin Hep C positif. You boleh target untuk jumpa mereka ataupun mendengar daripada mereka lebih. Bagi appointment, jumpa dia 15 minit. Konsultasi dengan tanya khabar, mendengar. So this is one way to tarik your patient to the rawatan dan juga confirmation lah. Bersikap profesional dan bertanggungjawab, saya rasa itu sudah tentu. Kita semua sebagai healthcare workers perlu stress benda ni. Saya rasa guideline tu semua dah ada. So how we counsel the patient, how kita cari patient-patient daripada kita punya pool to close the gap. Because tadi kita kata jurang Hep C program sekarang adalah mereka yang Hep C positif, kita tak tahu di mana mereka. Kita kena cari mereka. Ataupun kita tahu di mana mereka tetapi tidak kita sambungkan dia ke rawatan. The cascade of care, they are not linked to treatment. So we need to start doing something more proactive daripada kita duduk dan tunggu mereka datang sendiri. Sebab Hep C macam video tadi kata is a silent killer. Hep C is a silent killer. So when it's silent killer, a lot of them they don't know they have been infected by Hep C. Okay. So itu adalah tentang individu. Saya rasa last kali saya sentuh sedikit tentang kempen kesedaran dan juga kerjasama komuniti. Saya rasa pencarian Hep C ini juga bukan setakat dalam klinik kita saja. Saya rasa sangat penting untuk setiap klinik mengikut kepada you punya kesesuaian, cuba untuk reach out juga kepada komuniti. Dan komuniti di Malaysia terutamanya adalah beberapa komuniti yang kita tadi beberapa speaker sudah sentuh. Banyak kali kita ulang MSM, PWID, mereka yang ada tattoo, mereka yang mungkin sebelum ni pernah blood transfusion dan sebagainya. Those are people yang kita kena target. So when you design the thing, you need to design to see how you target them. So this I just tunjukkan di Majlis AIDS Malaysia sebenarnya MAC sudah start buat Hep C punya testing dan mereka sekarang ada buat self-testing punya study, research on Hep C self-testing dengan fine. So ini adalah salah satu projek yang sedang dijalankan. Tetapi ongoingly anda boleh nampak these are the social media punya awareness campaign, campaign kesedaran yang kita lakukan dari segi NGO. Dan Kementerian Kesihatan pun ada buat kempen kesedaran secara online dalam Facebook, KKM dan sebagainya. So macam ini adalah seorang transgender yang dia kongsikan bahawa dia sudah hampir 20, saya rasa mungkin ada silap sikit lah, 20 tahun menunggu ubat. So, tapi dia sekarang sudah cure from Hep C. So these are the positive story yang dikongsikan oleh mereka dalam social media. So in your clinic, kalau you ada jalankan Facebook dan juga online page, you can do promotion like this to welcome your patient to your clinic. Dan juga Hari Hepatitis Sedunia setiap tahun bulan Julai is macam HIV kita Disember 1, tapi untuk hepatitis is 28 Julai. So we can do campaign seperti ini untuk kita buat ujian Hep C untuk target group lah, untuk screen kita punya patient on a certain target group. Dan saya rasa dalam kerja Hep C respond ini, dia bukan setakat saja pakar gastro punya kerja, bukan setakat saja hospital punya kerja, bukan saja ID klinik punya kerja. Dia juga klinik kesihatan memainkan satu peranan yang very penting. Dan PKD dan JKN juga sangat penting because you all are the one that coordinate dan juga facilitate NGO dan juga agensi lain seperti AADK, seperti NGO, program pertukaran jarum suntikan untuk mereka rujuk patient kepada klinik anda. Dan juga sektor Hep C, HIV dan juga Majlis AIDS Malaysia. Saya rasa this is all the partnership effort yang kita sama-sama membantu dalam kita make sure patient kita dapat rawatan. So itu sebabnya dari segi tak kiralah di mana anda berada, anda cuba involve ataupun cuba libatkan Majlis AIDS Malaysia dan juga NGO tempatan. Saya rasa di Selangor kebanyakannya adalah hanya satu saja kalau tak silap saya untuk drug user, tetapi ada NGO lain yang buat untuk sexual transmission. So jadi Insaf Muni, Persatuan Insaf Muni adalah satu NGO yang buat program untuk mereka pengguna dadah. Ataupun kadang-kadang ada yang you ada kontak dengan pengasih, you ada kontak dengan pemadam. So kalau mereka ada reach out to drug user, AADK. So AADK agensi lain. So program saya rasa Petaling very aktif ialah AADK, mereka buat saringan juga untuk hepatitis C patient dengan kerjasama PKD dan KK. So these are the contoh-contoh dalam kerja harian anda, cuba libatkan NGO community dalam you punya perbincangan. Perbincangan dari segi klinik ke, dari segi PKD ke, dari segi national state level juga. So all this boleh berlaku. Dan dengan mendengar lebih daripada pesakit anda boleh dapat tahu di mana patient ini. di mana anda boleh design program yang boleh reach out to them. Bagaimana anda boleh design your saringan program di KK anda supaya anda boleh saring mereka dan rawat mereka. Okay, so saya rasa itu adalah dari segi kerjasama komuniti. So saya sentuh pasal individual, pasal jurang, pasal individual, bagaimana kita boleh approach patient, dan juga lastly bagaimana kita boleh kerjasama dengan NGO community untuk kita sambung patient kita kepada program rawatan. Dan saya rasa sampai sini saja saya punya sesi 45 minit, dan ada apa-apa soalan you boleh tanya kalau saya boleh bantu. Dan slide terakhir ini saya contribute kepada Pak Long lah. Pak Long merupakan kita punya pejuang Hep C yang bekerja keras. Memang selalu saya ikut dia outreach pun dulu masa Majlis AIDS Malaysia ke Felda dan sebagainya. Selalu saja dia cakap pasal HIV dan Hep C. Dan dia walaupun dia dapat rawatan, tapi saya rasa dia terlalu lambat. Dia meninggal dunia awal tahun inilah. Saya rasa itu adalah benda yang sangat sayang, dan kita doakan kalau kita boleh kuatkan kita punya effort to make sure all our patient in our care, especially in the facility, is being treated and is being rawat. So saya rasa itu daripada saya sebagai penutup lah. Ya. Terima kasih. Dan Urus Setia, ada soalan ke? Terima kasih banyak-banyak sebab menjemput. Ada soalan tak daripada peserta? Siapa-siapa nak tanya ke? Boleh unmute. Alright. Kalau tak ada, saya pass balik kepada pihak Urus Setia. Terima kasih banyak-banyak sebab memberi peluang kepada saya, kepada tim PKD lah. Ya.
Terima kasih Encik Hanyang pada informative and interesting talk. Seterusnya pembentangan terakhir berkenaan return hepatitis. Penceramah dijemput penceramah Encik Syahrizam bin Abdul Sani, MA ataupun penolong pegawai perubatan daripada Klinik Kesihatan Seri Kembangan.
Selamat pagi. Boleh dengar tak? Boleh dengar ke?
Boleh.
Alright, thank you.
Sebelum itu, untuk PKD Petaling, saya ingin memaklumkan bahawa kita ada sebanyak 390 kit untuk screening hepatitis C. So kita akan agihkan 50 kit setiap KK. Kita ada 7 KK, kita akan agihkan 50 kepada setiap KK. Bermula minggu depan lah. Okey, Syah.
Assalamualaikum. Selamat pagi. Boleh saya mula?
Tak dengar suara, Syah.
Bismillahirrahmanirrahim. Assalamualaikum dan selamat pagi. Boleh dengar suara saya? Dengar tak?
Boleh dengar, boleh.
Alright. So hari ini saya akan bercakap tentang return. Saya sebenarnya menggantikan Cik Zunaidi yang tak dapat hadir. Alright. So untuk return hepatitis C, kita akan terbahagi kepada dua. Saya akan share screen. So ini adalah line listing untuk perawatan Hep C. Nampak tak? Nampak? Nampak ke? Any respon?
Nampak.
So ini adalah line listing rawatan Hep C. Untuk Hep C ada dua. Pertama line listing, yang kedua adalah return. Ini adalah format pemantauan rawatan di AA. Untuk format rawatan di AA ni, kita kebanyakannya kita link dengan doktor, dengan farmasis lah. Alright, so ini saya bagi contoh. Yang pertama, ini adalah format dia, Selangor facility, KK masing-masing. Okey, nama pesakit, nombor IC, umur, bangsa, gender. Ini adalah dia punya data-data yang penting lah. Okey, and then diagnosa dia. Untuk link untuk tarikh anti-HCV, ini adalah penting. Saya tak pasti KK lain ada tak ada, sebab saya dapat tau sebenarnya kit ni. Saya ada beberapa kotak. Saya tak pasti kenapa KK lain tak dapat. Saya rasa saya dapat ni daripada JKN Selangor. Kita ada meeting tahun lepas bulan Jun, 9 hari bulan Jun. So tak apa. Petaling akan dapat macam cakap tadi. So kita berasa boleh start kot. Alright. So ini adalah tarikh anti-HCV. Lepas tu ini adalah tarikh HCV RNA. Alright. So bila dah buat tu dapat positif, kita proceed juga ni. Ini adalah detail-detail return yang kena tulis lah, kena type. So ini genotype, lepas tu faktor risiko. Macam tadi Dr. Vicky, Dr. Rubinda semua dah cakap tentang faktor risiko, menyuntik dadah, transformasi, transplant organ, NSI, tattoo, body piercing. Alright, so untuk unknown, alright, untuk unknown, contoh-contoh lain untuk unknown adalah contohnya ada HIV infection, ada masalah liver disease, ada history of medical procedure, contohnya ada surgery, biopsi, endoskopi, lepas tu elevated ALT level, itu antara unknown atau yang lain-lain lah. Alright. So ada yang ini pula untuk infeksi baru. Infeksi baru adalah infeksi baru atau reinfection, which mean before this dia dah ada Hep C, and then sebab kita tak dapat treatment lagi kan, so kebanyakannya semua adalah infeksi baru. And then co-infection pula, co-infection yang ini adalah senarai-senarai dia, ada HCV HIV, HCV Hep B, HCV HIV Hep B, HCV dengan TB ataupun others. Others ni yang lain-lain lah. Alright. So yang ini adalah tarikh mula rawatan, sama ada dia dah mula ataupun belum. And then tempoh rawatan. Alright, tempoh rawatan biasanya kita untuk PKD Petaling 12 minggu lah. 12 minggu. Kalau 24 minggu tu jarang kita jumpa, 12 minggu. Status rawatan dia, yang ini kita kena follow up. Sebab return ni adalah Januari, Jun, Julai, Disember. Dia 6 bulan. So kita kena follow up yang kat sini sama ada lengkap atau tak lengkap. Lepas tu status dia sama ada masih dalam rawatan ataupun dah komplit. Bila dah komplit, macam Dr. Vicky cakap tadi, bila dah komplit selepas 12 minggu kita kena repeat SVR. SVR tu apa? Sustained Virologic Response. 2 minggu lah, sama ada kita nak check ada tak lagi virus Hep C tu dalam darah dia. Alright. So kat sini lepas 12 minggu tarikh habis tu, habis treatment dia, and then 12 minggu lepas tu baru kita check SVR. So kat sini hujung sekali adalah Sulfus Bube di kelas tabik, ubat. Ini basically ubat lah. Ubat ni kita dapat daripada farmasi. Macam Amy cakap tadi, farmasi berapa dos yang kita bagi. 400 untuk Sulfus Bube dengan 60 untuk di kelas tabik. Alright, ini yang pertama. Kalaulah kata tak ada idea untuk tulis apa-apa, kat sini ada dua ni, ada don't delete list drop. Ini JKN dah sediakan. Ini adalah detail-detail yang kena isi. Alright. So sama je semua. So ini don't delete ni panduan untuk kita lah. Saya rasa semua boleh faham kot, kan? Senang je. Alright. So ini yang pertama. Okay. Untuk yang kedua adalah return Hep C. Ini adalah contoh untuk return Hep C. Januari, Februari, March, April, Mei, ini adalah contoh. Okey, bulan. untuk retain anti-HCV. Kat sini yang kit yang kita dapat ni, kit ni nanti kita akan dapat. So boleh buat. Okey, macam mana nak tahu berapa orang? Untuk klinik saya, saya continue yang DNDi yang dulu. Kita buku. So boleh masukkan sebagai buku daftar HCV screening register. Lepas tu ini adalah detail dia. Nombor registration, nama, IC, tarikh, nationality, boleh isilah. So RDT date, sample type, fingerprint ataupun venous blood. So ini kalau tak ada, mana-mana KK yang tak ada boleh buat sendirilah. Kita buat soft copy je dalam komputer ataupun dalam laptop. Okay, boleh tangkap gambar ataupun boleh screenshot. And then next is ni contoh dia lah. Contoh dia, okay, faktor risiko ni bergantung kepada klinik masing-masing lah. Macam saya punya dekat buku DNDi ni dah ada faktor risiko dia. Dia dah siap tulis. Yang tadi yang Encik Han yang tunjuk tadi tu kan faktor risiko dia. So lebih mudah lah. Alright. So ujung sekali adalah okay, ni timing dia lah. Timing dia, sample blood type, so result dia. And then ujung ni adalah hospital referral. Untuk kalau ada yang buku DNDi ni lebih mudah lah sebenarnya. Kalau tak ada, at least sediakan satu untuk registration book sebagai panduan kalau ada audit ke apa-apa. Alright.
Syah,
so,
ada yang tak nampak slide.
Tak nampak slide. Ini ada tak nampak slide? Saya dah share screen untuk slide. Nampak ke?
Nampak, cantik, jelas.
Okay, ini saya ulang balik. Ini adalah buku dia. Kalau tak ada boleh buat sendiri. Ini adalah detail dia. Ini adalah registration date, nama, IC. Inilah detail-detail dia. Yang penting adalah tarikh, HCV. Lepas tu kalau perlu rujuk ke hospital, ada rujuk hospital mana. Biasanya sini Ampang, Selayang, Sungai Buloh. Alright. And then ni contoh-contoh lah. Okay, ini adalah kit yang saya cakapkan tadi.
Slide tak bergerak, Syah.
Slide tak bergerak.
Cantik je.
Nampak? Sorry lah, first time. Okay, ini adalah contoh HCV rapid test kit. Okay. Alright. So kita pergi kepada return Hep C tadi. Return Hep C ni sangat mudah sebenarnya sebab dia dah format dia, kita boleh tahu. Januari kalau boleh jangan delete apa? Januari terus hantar. Februari terus hantar. Kalau boleh kita sediakan macam ni, Januari, Februari, Mac, April, Mei. Kalau boleh tambah Jun. Habis 6 bulan and then boleh hantar. Itu lebih mudah penghantaran untuk kita tengok format return tu. Alright. So bilangan individu yang disaring 1 bulan berapa banyak? Lepas tu bilangan anti-HCV positif. Sinilah kita kena follow up berapa banyak HCV positif. Lepas tu kat sini detail-detail dia. Patient with inject drug, unsafe sex. Lagi. Aduh. Sorry guys. Okay, sekarang saya berada di saringan dan keputusan anti-HCV mengikut risk factor. Alright, risk factor dekat sini ada PWID, unsafe sexual, transfusi darah, HD, satu, STI, transmission ibu kepada anak. Lepas tu yang hujung ni ada beza tau, lain-lain dengan unknown. Okay, untuk lain-lain, apa yang saya dapat daripada meeting JKN dulu, lain-lain adalah tak ada daripada PWID, lain-lain daripada yang saya tunjuk ni, tattoo, kesihatan dalam, transmisi ibu anak. Untuk unknown, apa yang saya tak adalah tak diketahui, tiba-tiba je dapat. Ataupun dia tak ada, antara risiko-risiko tu tak ada. Okay. So HIV infection antara lain-lain adalah HIV infection, intranasal drug, yang liver disease, history of medical procedure, elevated alternate level. Yang itulah antara lain-lain, and then unknown. Unknown ni memang kita tak tahu punca dia apa-apa. Alright, itu adalah format saringan HCV. Alright, so return ni nak hantar kat mana? Return ni hantar dekat 8selangor@gmail.com. AID8selangor SELANGOR@gmail.com. 8selangor@gmail.com. Dan return ni kalau boleh hantar macam saya cakap tadi 6 bulan lah. Januari, Jun, Julai, Disember. Okay. So return ni sangat senang. Yang penting kita link dengan farmasis dengan doktor. Lepas tu tugas kita untuk MA ataupun nurses buat saringan lah. Bila doktor datang, katanya doktor nak order, so kita buat je macam prosedur yang kita buat di DNDi dulu. HCV tu yang pakai finger prick, pakai 2 drop. Lepas tu kita wait for 15 minutes. Okay? Ada apa-apa soalan tak? Ada apa-apa soalan nak tanya? Okey ke? Kalau tak ada apa-apa, saya serahkan balik pada urus setia.
Dekat chat.
Dekat chat. Adakah line listing perlu diisi sekiranya pesakit tidak mula rawatan di KK, just saringan KK? Okey, untuk line listing tu adalah patient yang nak dapatkan rawatan. Dia beza dengan return. Return adalah berapa banyak yang kita saring. Untuk line listing tu, patient yang dapat rawatan. Tak mula rawatan, tak perlu. Sebab dalam line listing tu dia ada tarikh mula rawatan, komplit atau tak komplit rawatan. Lepas tu ubat apa, berapa banyak dia ambil. Di kelas tabir berapa, surface tabir tu berapa. So, yang tak mula rawatan tak payah masuk dalam line listing. Untuk HCV, berapa banyak kita buat dalam bulan-bulan tu, masuk dalam return. Okay? Ada soalan lagi? Ada slide lain selain listing. Okey, patient methadone. Sebab tu kita cakap untuk HCV ni siapa yang terima rawatan. Dia tak kira patient methadone ke, patient HCV, patient HIV ke, patient buat tattoo ke, tiba-tiba dia buat tattoo and positif. Pop-up positif and then dia kena buat treatment. So masuk dalam line listing. And then at the same time, nama dia juga masuk dalam return. Return untuk HCV, penggunaan HCV tu. Kat situ kita boleh tally kan dengan line listing dengan return. Line listing tu yang penting tak kisah mana-mana patient, methadone ke, apa-apa ke, kalau dia doktor kata dia kena on treatment dan masuk dalam return line listing tu. Okey? Walau empty patient dah lama diagnose, semua baru start treatment. Yes. Walaupun yang penting dia dapat treatment. Sebab dalam line listing tu ada bila dia start treatment, bila dia habis treatment, perlu tak buat SVR. Walaupun MMT patient tu dah lama, kena buat juga. Sebab tu dia ada diagnose dia, viral Hep C. Ada diagnose dia yang lain-lain lah. Kalau tengok line listing tu, harap semua dapat file, dapat kalau tuan-tuan dapat dia punya format ni nanti boleh tengok baru faham. Senang je dia punya tu. Cuma link dengan farmasis, link dengan doctors. Patient yang dapat treatment mesti masuk dalam line listing. Tak kisahlah dia dah lama ke, dia baru ke. Kat situ kita dapat data dia. Alright. Ada apa persoalan lagi? Daripada PKD Kuala Langat, PKD Gombak. Harap clear. Lagi? Okey, kalaulah kata pasal return untuk buku daftar, kalaulah tak ada secara fizikal, boleh je buat dalam secara apa, buat dalam online ataupun kita pakai Excel tu kan. Kita pakai Excel tu buat je, at least ada nama, ada IC, ada detail dia sikit, and then keputusan. Itu pun dah cukup dah. At least kita tahu patient 1 bulan berapa, and then siapa patient dia. Okey. Saya rasa itu saja kot. Ada apa soalan lagi? Tak ada Okey, harap semua clear. Saya serahkan baliklah kepada urus dia. Terima kasih. Maaf atas kekangan kalau ada masalah teknikal. First time.
Yeah, it's okay. Syah. Okay, terima kasih banyak. Okay, finally we came to the end part of our presentation. Okay, I would like to say thank you again to the presenter, all presenter for the informative and interesting talk, and also to the audience for active participation. Hopefully the presentation will be beneficial for everybody. Okay, thank you all for your attention. Assalamualaikum warahmatullahi wabarakatuh. Nanti slide kita akan emailkan ya.
Isi kehadiran dulu.
Jangan lupa isi kehadiran baru boleh kita email slide.
Eh,